Yeah, of course, yes. I think you should kick it off. Continue. So we can start.
Good morning. Sabah al-khair. Bonjour. Buenos dias. What language are you going to use today?
English and French.
And French.
Yeah, the translator. Yeah.
Ah.
We have live translation.
How many people here speak English?
Vast majority. Skip.
الله سعادة الرئيس.
Skip French.
How about French? How about Spanish? Ah. How about Arabic? How about Amazigh? Oh my God. So, Jan, this is multiculturalism in action. 5 languages. People speak 5 languages here. And in the United States, how many languages? 1. Do you know that saying, the question is, what do you call a person who speaks only 1 language? An American. I'm sorry. But we are very pro-American here. We love the United States. So I have nothing to do with this conference. My name is Anwar Majid. I'm the Vice President of the University of New England. I am the Managing Director of this campus. And I just wanted to welcome you to a great day of events and panels and discussions about this very, very important topic of occupational therapy in Morocco. I'm extremely honored to be here with Saeed, who is the founding president of the Moroccan Association of Occupational Therapists of Morocco. And we have a very big occupational therapy program at the University of New England.
Yes.
And we have faculty, very distinguished faculty from the program. I can see some of them in the back. And some of them had been in Morocco before, some of them a long time ago, that's Jen. And we have also students who are joining them from the University of New England. Okay, raise your hand, students from UNE. Okay, so that's a big number of students. So they came all the way from the United States to be part of your conference. We also have a few members of the physical therapy program, and I see the faculty member Sally there. And so it's, and how many nationalities do we have here today? I want to hear the names of countries. Jordan. Lebanon. Saudi? Oh, wow.
That's no.
Okay. Okay, more names? Huh? Germany.
America. USA.
Spain. Okay. Morocco.
America.
America.
We have Colombia. Do we have Colombia? Yes.
Colombia.
Kenya.
Who do we have? Moses, Kenya.
Kenya. All right. I just want to tell you, we are very honored today too to have the Tangier is part of a region. It's called Tangier. It's like the state of Maine, the state of New Hampshire, the state of New York. And like the United States, each state has a major public university. I just want to tell you, in case you didn't know, the president of that university system is right here, Mr. Rami. And his vice president, Bushra Mumni, is a very good friend of mine, a good friend of UNE's. He's right there next to him. And Si Mohammed, the dean of the college, Tangier has just established a college of medicine for the first time ever. And it's a huge building, very modern, sophisticated. It's going to be one of the best colleges of medicine in Morocco. And the dean is right here with us, Mohammed. And I'm so honored that they joined us at this early hour, which is, I mean, it's not easy for. And so, welcome. Have a great conference. And now I'm going to leave you with Saeed, who is he's the organizer, the founder, the president, and the great faculty.
Assalamu alaikum. Thank you, Dr. Majid, for this introduction. And again, I admire what UNE has done, creating this massive project and amazing building here in Morocco to spread knowledge and build bridges between Morocco and the United States instead of walls. And we are so honored to be part of this, bringing people together. And you can see here as well. So all of this cannot have happened without the help of UNE, of course, and the big man, Murad bin Kiran, who is there, and Zubair, who is also there. And so there are a lot of people who work behind the scene that could not, that events could not have happened without their help. I will also thank the president of AOTA, who will be our keynote here, American Occupational Therapy Association, and the guests from all over the globe joining this in this event. I would also like to thank the students. We have students from Columbia University, from NYIT, students from Tufts University, and students also from Toro and from Buffalo College as well. So we have students come from all over the United States to be part of this as well. And also we have people, I'm sure, watching live from all over the globe as well. Also, this event could not have happened without the help of Global Impact that helps fund parts of this event. And Professor Brahimi is the co-founder of this organization with me. And he will be saying some word as well.
I am deeply indebted to everyone that has contributed to putting this together. So I'm going to skip naming names because I don't want to leave anybody out. But the audience has tripled in size from last year, as Dr. Majid could attest to that. The only thing is I looked at the program, and it's pretty thick. If you have one, feel it. So all I gotta have to say is, please stick to the time that is allotted to you. Okay, we're gonna have a time stacker sitting in the back, so when it's your time and you get 10 minutes, we're gonna be raising signs. You got 5 minutes, you got 3, so there's a countdown. When it's time for you to leave, we're just gonna have to pull the plug on you. So let's do that, let's stick to the time. Again, thank you all for coming here, respected speakers, guests, dignitaries, the audience, thank you all. Give a round of applause to all of you, and let's kick this off. Thank you.
I just want to mention yesterday we had the pre-conference, and it was amazing. It was fascinating as well with the 2 presentations. So we hope next time we do a conference, the pre-conference, also you can join us as well. So now we'll start with our first victim. Dr. Moses Ikiugu is a dear friend of mine, and we have been all over the globe together with Colombia, South Africa, and so many countries that we share a room together. And we are so honored to have him. And he does not snore, I swear. So Dr. Ikiugu, he is one of the famous OTs in the globe. And he wrote so many books, so many research studies, and I'm so honored to have him as one of our speakers. Dr. Ikiugu is a professor and the director of research in the Occupational Therapy program at the University of South Dakota, USA. He has been an occupational therapist for 34 years and has conducted research and published articles extensively covering occupational therapy theory, occupational science, and the nature and use of meaningful occupations in therapy. His publication include 3 books: Psychosocial Conceptual Praxis Model, 2007, Occupational Science in the Service of Gaia, 2008, and Meaningful Living Through Occupations, A Guide to the Everyday Life. And actually, this is a book I use in my class that I teach in the USA. With Nick Pollard of University of in England. University of Harlem in England. Dr. Ikiugu is the USA delegate in the World Federation of Occupational Therapists. So his presentation will be about human beings are the authors of meaning in their existence. Occupational therapists are the architects to help them construct ultimately meaningful lives. So we can. I have your thing.
Okay, good morning. Well, thank you very much, Said. That was a very generous introduction. And I have to be mindful of time, so we better get going. All right, let me see. I figured it out. Probably what I would like to do, given the short time, is first of all to start with the background to this presentation, which is about the idea that human beings are the authors of meaning in their lives. And actually, as occupational therapists, maybe we need to take our position as architects to help people construct meaningful lives. So where did this idea come from? This actually is one of the things I've been doing for a long time now. When I went for my doctorate, I decided to look at the philosophical foundations of occupational therapy. And in the course of my studies, I actually came to learn that pragmatism was the foundation of occupational therapy. And so I wanted to find a way of practicing that was consistent with the pragmatism. So I decided to be foolish enough to jump into something that many people who are wiser than me would not do, to create a theoretical model. So I created instrumentalism in occupational therapy based on the doctrine of the mind as a tool for adaptation, which was from Dewey's philosophy. But then, as you know, philosophy does not really translate into practice, so I needed science. The pragmatists were highly influenced by the theory of evolution, but I didn't think Darwin's theory of evolution worked very well with OT, so I discovered something known as complexity theory, how complex dynamic or adaptive systems work, and I thought that's a very good theory to do that. So complex systems are they have a trajectory, they have self-similar characteristics, which means if we examine it at a smaller scale, it represents the entire trajectory. But they also have something known as attractors that structure the trajectory of the system. I thought at the time that the attractor for occupational life as a trajectory, as a complex system, would be purposefulness. So we did a retro study to test that, and we found that actually purposefulness is not the attractor. Rather, the attractor is meaningfulness. What structures people's occupational routines is the extent to which those occupations contribute towards a meaningful target, which could be earning a degree or a better relationship or whatever it is, or a career. And so that's how I got into studying meaningfulness. So in the course of my studies, what I've realized is that I'm not the only one interested in meaningfulness. Philosophers, psychologists the world over have always done that. Psychologists like our friend Andra talked about the fact that human lives are structured by higher order goals. By higher order goals, he meant goals about making an impact in life and, finding that we matter. We want when to leave this world, we want someone to say that we had an impact, some kind of impact. Viktor Frankl, who was a prisoner in Auschwitz during the Nazi Germany, went on to develop the theory of the therapy of logotherapy. And he's saying that human beings have a will to meaning. What actually motivates human beings is a search for meaning. So jumping off from that, he also talked about some of the things that make human life meaningful. One is using one's creativity to contribute to a cause that is bigger than oneself. Another one is the love and joy of connecting with the environment and other people, so not being isolated. And then even when someone is suffering, they still can have meaning in their lives. It is the attitude, it's how you respond to circumstances in your life, not necessarily what you are experiencing. So you can find meaning even in suffering by having a different attitude. And then self-transcendence, trying to serve something other than oneself. So according to Frankl, if you are too focused on yourself, that's not how to find happiness and the meaningfulness. In order to find the meaning, you need to transcend yourself and serve something bigger than yourself, be a part of something bigger than yourself. So based on that, I started looking at what specifically, we talk a lot in occupational therapy about meaning for occupation. So what is it? So I started looking at how we serve meaningful lives using occupations. And so then I started thinking, why are we as occupational therapists not trying to do that? Why are we not trying to help people find meaning by connecting with others, with nature, by transcending themselves through what they choose to do every day? And so myself and some colleagues did a retro study, which I replicated later in South Africa. And what we found is that meaningful occupations are fundamentally different from what we thought. We thought that meaningful occupations make you all happy and exhilarated, excited. What I found was that actually sometimes meaningful occupations don't do that. Sometimes meaningful things actually cause you anxiety and pain and so forth. But the end is good. But when you are doing it, ask any student here, they'll tell you. They are doing something meaningful, but the journey to get there is not always so enjoyable. So that's different from what I would call psychologically rewarding occupations, which are perceived as fun for the most part. But whether they are all meaningful occupations, including those that cause a lot of happiness and psychological rewards, they tend to also be seen as both physically and mentally stimulating, as well as connecting someone with other people, so inducing isolation. And so I thought that the best way to help people structure their lives is by using occupations that have those characteristics. They are fun, they are physically and mentally stimulating, and they connect people with others. So, how would therapy look like? And now I will try to rush through because I know time is almost over. So, it starts with the initial interview. So you interview the person you are working with to try to establish an occupational profile. In the United States, the AOTA has developed the occupational profile template, so I use that every time to try to find out what is important for people, what do they see as their goals in life, and so forth. Then I administer an instrument from the model that I created, instrumentalism in occupational therapy. This assessment has a long name, assessment and intervention instrument for instrumentalism in occupational therapy. And the way it works is that actually this is borrowed from the work of James Covey. Those who might have read his work, 7 Habits of Most Influential People, How to Live Principle-Centered Life. And so translating this to occupational therapy, what I ask people to do is through guided imagery. Now, Covey asks someone to imagine what they would like to hear people say about them in a eulogy. Now, considering that we work with the people who may have depression and other things, I don't want to bring eulogy into the picture. So I said, okay, the imagination is, let's suppose that you have been away for some time on a journey, you come home, you find there's a gathering of people, they are talking about you. What would you like to hear them say about you? And so a family member, a friend, a colleague, a community member, and by writing down those statements, then I say, okay, now based on those statements, draft what you may consider to be your personal mission in life. So if you have a personal mission in life, then you have a kind of legacy that you want to create with your life. Once you have that, then the next step is, how do you make sure you live that life? We tell our stories through the occupations in which we participate. So I say, okay, choose an occupation in each of those 4 areas that if you performed it well, it will help you achieve that mission and then create the legacy that you want. And then, of course, the person rates themselves in how frequently they think they perform it, how adequately, how satisfying they are, and how well they believe they can perform it. So after that rating, then that becomes a basis for goal development. So once you have that, then the next thing is, of course, being a theory person. I think that we should be doing person-centered, theory-based, evidence-based practice. And this is another way of practicing that we developed with some colleagues, which we call eclectic application of theory. So this means that based on how the person presents, you choose a theoretical model that would be the organizing model of practice. That becomes the lens through which you see the person's life and issues. So in the mission statement, if let's say someone wants to live a life where people say, you know, you were a nice person or whatever it is, but there is a self-doubt and you don't think that you can be able to achieve goals, we might say, those who are familiar with the Moho, you might say this person has a challenge in the volitional component of the human system. That means we need to use Moho as the lens through which to see this person. But as you continue working with the person, you need that they also lack certain skills. So you might say, okay, I need something that will give me the teaching learning skills to work with this person. So you might choose a behavioral approach in order to fulfill that. As you work with the person, you may find that they have some cognitive limitations, so you need to adjust the way they perform tasks so that they are able to do them. You may then think, well, I need to use the cognitive disabilities model. So this dynamic combination of models, you start working using this dynamic combination of models to help the person actually perform the things they need to perform in order to arrive at their mission, the mission they set for themselves. So as you do that, I don't know what happened here. Oh, okay. Then the next thing that I want to do, remember we said that the best occupations tend to be both meaningful and psychologically rewarding, so they need to be fun, to be mentally and physically stimulating, and they need to connect people with others. So how do we identify those? Because those are the ones that I want to use as media in therapy as we work towards this person's ultimate goals. In regard with this, we developed another assessment, which is known as the Meaningful and Psychologically Rewarding Occupation Rating Scale. So based on the interview, the mission statement, and so forth, we list all the occupations that the person identified, and then we have the person rate these occupations on those characteristics. To what extent is it perceived as fun or physically stimulating and so forth. Of course, there are negative reward and versions of those in order to avoid coercion bias. And then you add the ratings. We have a system of scoring. In the end, you have the occupation which is rated the highest in meaningfulness as well as the highest in psychological reward. Now for this particular person, this is just a section of it. You can see then it is schoolwork was the most meaningful, and playing or taking care of our dog was the most fun. So basically what you want to do in the end is then to use those kinds of occupations that involve taking care of a pet, as well as combining that with the schoolwork as a way of structuring daily interventions. Now, of course, there are other things that are here about the intervention itself, but basically that is the gist of this approach. So, thank you very much. And
So you find my presentation? Can you find my PowerPoint? I don't know. While these men are fussing,
that
I'm
it?
going to say a few things.
It's going to be number 2.
Oh,
That made it easier for us.
oh, you put numbers on them. How smart.
It's here.
It was in order.
Yeah, it's 2.
You, no problem. There you go. Two.
Yes. I have it, thank you.
You may have to hold intro
Yeah.
again.
Yeah, so just for the sake of the time, we have, if you have this, you will learn about the speakers, but quickly, Dr. Anne McRae, she is a professor she was a professor at San Jose University, State University, but she's famous about mental health and occupational therapy, because occupational therapy also addresses mental health. And she did an amazing presentation yesterday for 2 hours talking about the mental health and also how OT can address issues in mental health. So we are honored to have you. Hi.
Thank you. I am hoping, we're still going to work it out, how to make sure that the PowerPoint slides are available to everyone. I also have my business cards with me. If you have trouble accessing any material, please feel free to email me anytime. I would be happy to send you any of my work. So, the title of this paper is Understanding and Reducing the Stigma of Mental Illness. I specified mental illness for 3 reasons, actually. One, it happens to be my practice area, and it's the area I know the most about. 2, it's because I realize in many parts of the world, occupational therapy needs a little more work on how to address mental illness. But 3, and probably the most important, is that people with mental illness are the most stigmatized and marginalized group in the world. And there's data on that. The stigma that they experience is quite severe. Now, having said that, I am hoping that this presentation is applicable to all of you. No matter who you work with, there are people with various disabilities, various life events, not necessarily even related to health, but other areas where they are marginalized from society and they do experience stigma. So I will specify mental illness in some ways, but hopefully you can generalize it to whatever population you work with. Okay? Again, on this presentation, my email is available. Please feel free to contact me at any time. All right, here's the goals. I'm not going to spend time reading them. They're really for your edification, but what I'm trying to accomplish today is help you understand what stigma actually is and what you can do about it. An overall goal up at the top there is, if there's one thing I hope to accomplish in this short amount of time, is to give you some structure for you to examine your own beliefs. Stigma begins at home, and all of us have our prejudices, whether we want to acknowledge it or not, and we have to examine our own beliefs and our own level of awareness. So hopefully this helps. First of all, what is stigma? The top one there is my own definition that I use in my own writings. A constellation of negative and unjust beliefs, typically based on very superficial, stereotypical generalizations, and it does result in prejudice and discrimination. Another definition that I've used that I like very much is from a 2006 article, a cultural disease that marks its victims as morally tainted. The reason I like this particular definition is because that's what happens in our own minds. If we can rationalize that the other, whoever it is somehow inferior, less of a person, doesn't deserve the same rights and respect that we have, then somehow we rationalize it and we justify it. And otherwise, good moral people engage in this behavior because they have decreased the value of the other. And that's why self-examination is so important. Do we hold these beliefs about other people that make them less than us? And so between those 2 definitions, you can get a good idea already of the kind of work we need to do in this area. Okay. In terms of how common is stigma, again, based on mental illness, studies have shown that over 90% of people who have a mental illness have experienced feeling stigmatized in their lifetime. So think about that in your own life, okay? If there's a 9 out of 10 chance that you are going to be made to feel less worthy, how is that going to affect your ability to engage in everyday life? Okay. It's devastating. So we think of it in terms of what I just said, does stigma hurting the individual person? And it does. I hear this from service users all the time. It's, yes, I know I have bipolar disorder or schizophrenia or depression or whatever, but what really gets in the way is what other people think of it. So again, this is a huge issue. It does hurt the individuals. But it also hurts society, who we are as a people, whatever country, whatever culture. And there's just a couple of quotes. The greatest cruelty is our casual blindness to the despair of others, when we lack the ability to feel empathy. Okay. So another quote from Bill Clinton, our former president in the United States. Mental illness is nothing to be ashamed of, but the stigma and bias shame us all. It represents who we are as a people, as a country, as a nation, as a culture. In my own writings, I have structured it to look at stigma in terms of 4 different types. And quickly, they are institutional stigma, self-stigma, concurrent stigma, and community and relation stigma. And I will go through these and define what they are. Give you some examples. Okay, institutional stigma is really the most overwhelming and insidious because we don't even recognize it for what it is. It's when governments and business develop policies that do discriminate and do stigmatize certain groups of people. In many cases, they are designed initially to be well-meaning. They think they're protecting society or increasing safety or something like that, but without even realizing it, the secondary effects are very discriminatory to certain groups of people, and they restrict options. This happens a lot with people with mental illness. These restrictions may be limiting people's choices of employment or housing or engage in basic civil rights, such as voting. So depending on the culture, depending on the nation, we do institutionally discriminate and stigmatize whole groups of people. Okay, so that's the first kind, institutional stigma. Then there's self-stigma. This is when an individual internalizes negative beliefs about themselves. And I'm sure you've all seen this happen. It happens with children. If they're constantly told you can't do something or you're not good at it or you're bad or you're ugly or whatever, they believe it. So this is one of the most damaging parts of stigma. And that makes your ability to engage in something like occupational therapy, to meet goals of recovery or rehabilitation, all the more difficult. They may have feelings of shame. Fear of labeling, particularly in mental health, it happens in other areas too, is a major problem. If they're afraid to have that label because it's so stigmatized, they're not going to seek help. So how do you get better if you cannot even acknowledge that you have a problem? So therefore, they are very resistant to treatment. It's like, I don't need those meds. There's nothing wrong with me. I don't need therapy. I don't need rehabilitation, because the self-stigma of acknowledging that is so painful. It can also lead, in more extreme cases, to hopelessness and despair. They may not have started out with depression, but they can end there, again, because of the external pressure, because of how other people are viewing them. This leads to secondary diagnoses. Many of people who have this self-stigma end up self-medicating. What I mean by that, they may use drugs or alcohol or other means to comfort themselves, to make themselves feel better. It also can lead to suicide. People with mental illness have the highest suicide rate in the world. And my belief, again, the data is a little difficult to show, my belief that that very high suicide rate is not limited to symptoms of the diagnosis, that it is a result of societal stigma and self-stigma. It's stuck. Okay, so we're up to the third one. How am I doing on time? 5 minutes, thank you. The third one is what I call concurrent stigma. This means when there are different kinds of stigma happening at the same time. I'll start with people with mental illness, but it could be other things. People who are also identified with other groups, that are stigmatized or discriminated against. Lack of acceptance and marginalization can be focused on any aspect of identity, including a physical disability, a cultural group, a religious group, secular affiliations, lifestyles, gender identification, sexual preferences, even body type. Now, the reason I bring this one up, I see it a lot in mental health care. First of all, in the United States, we have I think, a bad social problem with what we call body shaming, that everyone has to look like the perfect model you see in newspapers. And so, but people with mental health have a couple of problems with weight control, obesity. One, the medications often cause them to gain a tremendous amount of weight. And two, because of they're so excluded from daily living, they often have very sedentary lifestyles. They sit at home, they're isolated too much. So they're given medicine to help them feel better, and then they get excluded from daily activities, and so they have a lot of body image issues, which then even increases the stigma because some society judges people by their body types. So as you can see, it's a very complex issue. Sometimes you try to do something good and there's negative unintended consequences. So we got 3 of the 4, right? We got institutional, self-stigma, and concurrent stigma. You all with me? Okay. One more. Community and relational stigma. This is the more subtle category. Forms of stigma can be, even appear to be benign, even appear to be helpful. They are usually from well-meaning attempts to protect the individual with mental illness or other stigmatizing condition. I don't want to keep limiting it to mental illness. But what happens is that trying to protect someone prevents them from achieving recovery goals. Think of it in terms of a child. If you never let a child fall, if you never let a child fail, if you never let a child experience not succeeding, what happens? They don't learn it. Well, that's true of other people too. They need to at least be able to try. So here's some examples that I see in practice. Parents of an adult child with mental illness who insist that they remain at home rather than living independently. And by the way, I have never been to Morocco before, but I have been to many areas in the Mediterranean region and consult at the University of Malta across the sea. And I see a lot of similarities in the culture, and I do find, my guess is, tell me if I'm wrong, that these issues I'm bringing up are probably quite common in Malta. That you want to protect your family members, of course well-meaning, but are you preventing them, not realizing it, from becoming more independent themselves? I've seen it with physicians, I've seen it with faith leaders, and other community members who are pillars of the community. They often will be the ones who have more sway over an individual than a therapist. And they may be not meaning to hurt them, but telling them, oh no, you don't have to work, you can't do that. Whenever you tell someone they can't do it, they'll believe you. So occupational therapists often are the ones who say, yes, you can do this, and we'll help you adapt it, and we'll figure out a way. It's not always easy, but that's a role that OT has. And occupational therapists even fall into this trap themselves. Sometimes we're so afraid that someone may be fragile. Okay, we got to end? Okay. I could talk more. There's a whole lot of stigma reduction information here, and what someone can do. I hope you as a group get a hold of this PowerPoint, see what it is that you can actually do. I wanted to spend a lot more time on this, obviously. Okay, sorry for the lack of time. I wish I had more. That went too fast.
No, that's perfect. That's why we gave you 2 hours yesterday. That's why we gave you 2 hours yesterday. All right. As you can tell, that's why we gave Dr. Ann 2 hours yesterday to talk. All right, so Dr. Paula and Dr. Chris will be presenting together and about something related to pediatrics. So people who work with children, these are one of the best you can learn from. So Dr. Paula Lebe is an assistant professor in the OT graduate department in St. Catherine University, USA, and her clinical background is over 25 years of experience. And so there is more about her, but you can see it there. And Dr. Chris Winston is the director of the occupational therapy at the University of New England. And she also has over 34 years of experience that she's going to share with us as well. All right. You can find it. It's number 3, I think. So number 3. Okay, mark 3. Yes, yeah. Yeah, yeah. The little. Yes.
All right, we're going to get started so we can go quickly. Where does the time come? So we're going to talk a little bit about the idea of family-centered care and then how that relates to working with families around mealtime difficulties, mealtime disruption, because both of our clinical practice relates to families who've had disruptions in the mealtime experience with their child or children. So early elements of family-centered care, and I think for those of you who heard Dr. McCrae, where did she go? Is she here? Oh, there you are, right in the front. Speak yesterday, I started to think a little bit about the idea of family-centered care is really trying to move more towards a social model as opposed to a rehab model or a medical model, that we're really trying to think about families are the center, and that as therapists or medical professionals, we're just coming into their lives for brief moments, but that we really need to think about how we empower families because as this first bullet says, they're the constant in the child's life. We may be there for an hour or half an hour, but the family's there for the rest of the time. So the idea is that we're recognizing family strengths and individuality and respecting different methods of coping and different methods of thinking about how to move forward or how to create habits and routines around meal times. We're trying to understand and incorporate developmental needs of children and families into healthcare delivery systems and encourage and facilitate parent-to-parent support. So how do we connect families with other families who are experiencing similar things so that they feel supported, which may actually help a little bit to decrease stigma that might go along with that by having that kind of support. So looking to have assurance that we design healthcare delivery systems that are flexible and that are accessible and responsive to family needs. So not what we think people need, but really getting input from families as to how do they need things to work so that they're able to meet the needs of their family. And this is another one that I think is really interesting, and as the students are here to really start to think about this, but one of our roles is to share unbiased and complete information with parents about their child's care on a regular basis. So we have a lot of knowledge, but we need to impart that knowledge to families so that they feel empowered to make decisions that fit for their families. And sometimes they don't have the same access to information that we do. So really helping people get that in a supportive manner. So way back when I got my master's degree, some 30 years ago, I think, which is sort of sad. We had this great picture that was presented to us about a Copernican revolution, that instead of the medical model being the center of everything that was happening, that we should start to think about the fact that families are the center. And so we need to really shift our focus. And while that's been since the 1980s, I can still say that in 2020, we're still not there. We're still not really doing that idea of putting the family first or putting them at the center. So there's some literature that talks about what we think we're doing and what we're really not doing in terms of that. So there's tons of work to be done. And I'm so excited that there are so many students here who can sort of take this message forward and really start to think about how we put patients and families at the center of our service delivery systems. So I'm going to skip over this because I know Paula has a lot of things to share with you. related to specifically mealtime and thinking about this idea. So there's some really nice work being done by the Institute for Patient and Family-Centered Care. And so I added this website for folks to go to think about ways that you can structure your own practice. They use a couple of nice sort of mnemonics for us to think about that. And for families, the idea is together. So talking about their role, observing the changes and reporting those to caregivers, gathering information and making sure that you share that with caregivers, ensuring that you're present when decisions are being made, telling care providers about concerns that you have, helping with decision making, and then enlisting help and then readying yourself for transitions. So that's sort of from a family perspective. And then from our perspective as providers, presenting ourselves to the patient and family and care partners and really explaining what it is that we do, what our role is, and how we look forward to working together with that family. Asking care partners how they want to participate. Sometimes people dive right in and other people are more slow to accept that role. And so thinking about how do we help families feel comfortable taking that role of care provider. Reassuring care partners that they'll be heard and respected throughout the process. And I think as OTs, we're just really good at sort of that human connection and that idea of supporting families. Trusting that we share the same goals, that families' goals are our goals, and that that's what we want to help people move forward with. Nurturing our relationships, encouraging involvement, reviewing and agreeing upon details, and then supporting caregivers in their roles. So giving that support that people need in order to take on whatever it is that they need to take on to move forward. So if we go back to the idea of a Copernican revolution and the sun at the center or the family at the center, we sort of set this up to think a little bit about families who are having feeding challenges. And so they have schools to deal with and therapists to deal with and multiple medical professionals to deal with and insurance to think about if you're in our US system for sure. And so really putting the family at the center of that and then thinking about how we all rotate in and around that when working with families. So that was quick, but now we're gonna switch to talk a little bit more specifically about families and meal times.
Okay.
All right.
Is this your phone? Oh, okay. Okay, so I want to preface this a little bit first with how I got really interested in this. So the mealtime work that I'm going to present today is really from my dissertation. And those of you who heard me yesterday, I talked a lot about feeding and eating and that whole context. And from my experiences as a therapist, especially working with children between the ages of 0 and 5 years, I really got to work in the families' homes and realized early on that this was much bigger than just looking at the feeding issue that the child was referred to me for. And it really was about the occupation of mealtime and all that entailed. And about how it's a routine and how it's a ritual. So for my dissertation, I really dug into that work because when we're looking at family-centered care, we're looking at the routine of the family. And as you know, mealtime is an occupation that occurs several times a day, right? We all eat. We have to feed our children 3 to 5 times a day, especially when they're little. And this can be very stressful. So I want to talk first about present the words routine and ritual because these are really important, I think, words when you talk about mealtime. So routines and families structure their day, especially with young children. Those of you who have young children, think about or even think about when you were younger about how mealtime was like in your family and what were routines and rituals around that. So we think about routines as occupations that occur in the home on a daily basis, and they assist in organizing time, okay? They provide structure. So routines convey what needs to be done. What are all the things that need to be done from start to finish? And rituals are more of a form of symbolic communication that helps convey a family identity. So rituals convey this is who we are. And it can have very emotional involvement, symbolic involvement, and it integrates all of the family members as a whole. So I found this to be very, very important when working with families around feeding difficulties. Okay, so I'm trying to get this to... There we go. So we think about, this is just a definition of the mealtime experience, because I want you to think about, as I go through this, what mealtime or what eating together was like when you were a child, and maybe what it's like in your life right now, whether you have children at home or your children have grown. I have 5 children, and our mealtime has changed over the years. So, but it's I like this definition because many of you can relate to this, but especially mothers, densely packed events in which much has to happen in approximately 20 minutes. There's a lot, and it has, when you really dig into the construction of a mealtime experience, there's a lot to it. And so I broke it down into what comes within mealtime routines, because routines encompass communication, commitment, and continuity. And rituals are, remember we talked about symbolic, emotional, and integrating families. So, for example, communication can be direct or indirect. It can delineate roles. Who prepares the food? Maybe it's one person, or maybe partners switch off. Who sets up the eating space? And children and teenagers especially can be involved in that. And who picks up the last minute food items? How many of you I always call my husband as he's coming home, oops, we forgot the milk. Oh, we need the tomatoes for this, we need this. So commitment is how the task is accomplished from beginning to end. So I began to see mealtime as even from when the cooking started, because many of the children were affected by the smells and the sounds and everything happening in the kitchen. And what are the expectations that the parents had or the caregivers on the children? What was your parenting style? Were there rigid expectations that you need to sit and eat? Or did you eat with the television on? Do you sit on the floor? Or are children allowed to come and go in the kitchen? So we have that. And then the continuity part with the routine is that it gives us an organization for the day. Particularly for children are very routine oriented. So it gives the day meaning. And this can be very different for each family. And rituals are things that families, again, bring in as symbolism. Maybe they're passed down. It could be prayers and blessings. Sometimes there's inside jokes. Symbolic objects, I'll talk about that, which are only meaningful to one particular family because every family has different. And sometimes it's elements passed down from generation to generation. So an example of routine, I went out a limb and put some pictures of myself as in those awkward teenage years. I grew up in a family, my dad had 4 girls. So we each had rotating jobs that were part of the routine of mealtime. And you can see me and my younger sister having to wash dishes. That was one of the rules. And my dad always joked that he didn't need a dishwasher, an automatic dishwasher, because he had 4 of them. And so we all knew that was part of the routine. We knew there was a cycle. We were like, oh, nope, I cleared the table last time. Now it's your turn. And that was part of the whole mealtime. You could not leave the kitchen until your job was done. Present day, I have 4 boys. 1 girl, but 4 boys. And so this is my son. So I have them participate in the kitchen. So sometimes routines change. We have gender roles. They change from when we were little. So we all have, what is your routine? And children with disabilities need to be included in these routines. Rituals. So we talk about, I just gave some examples. So my favorite, this is my grandmother who passed away last year. I call it the famous milk pitcher. This milk pitcher was on the table with milk at every meal. Now, that could be considered a routine, but it was very ritualistic for me. And I was privileged enough to now I have this pitcher in my kitchen as a symbol of the meal times I shared with my grandmother. The more modern day, I call it the birthday placemat. This is what a ritual in our family sort of happened accidentally, and sometimes rituals do. And then it was my children who made it a ritual. We happened one day when the children were little. I was like the night before. I thought I'm going to make a cute little placemat, and I just took some paper and constructed this and had it on their place when they woke up in the morning for when they would eat breakfast. And then it was, the child loved it, and then it was the next child's birthday, and they were like, I wonder if I'm gonna get a birthday placemat. Oh, and so then we continued it, and then they started making the birthday placemats for each other as they got older. So this is the one, my son just turned 17 before Christmas, and this is the one that my husband made for him. So, and they went on, it became, and my children do not forget it. So it's an example of, we have rituals, and it ties us together around food and mealtime. So I want to talk about just the elements of mealtime that I think are very important, that I discovered that children learn. And mealtime, the whole occupation, is a huge learning experience, especially for small children. There's research that says that mealtimes, I love this quote, are vehicles and endpoints of culture. And first, children are observers of what happens of their culture at mealtime or food events, and then they become active participants. So the cultural knowledge and practices are co-created, so we have co-occupation within the families, co-created together as a family through those socially constructed relationships during mealtime. Okay, we have many different opportunities afforded by mealtime experiences. You can see that it fosters child development. Think of all the things they learned. I love this picture of my niece learning about the properties of her bowl and her food. They learn language, those things. So I just want to quickly share, I have 1 minute left. So for my dissertation, I used a photo voice methodology to study mealtime, which put cameras in the hands of mothers. I worked with African-American mothers who had young children, and they took photos and talked about their pictures, and a lot of what almost every mother discussed, how togetherness was at the heart of mealtime, and how it was important to being family, and how those children, some of them had tables that they sat at, some of them did other things, but it was the unity and together from beginning to end. And they really valued teaching their child and bringing them into the whole process. And these are some of the themes from the photo voice study. And one of them was, it was like a teaching moment. So I'll end with bringing it back to family-centered care. And this is a little guy. I want to tell you a quote from one mother that I think brings back to what Chris said very well. This mother who had a little boy very, very ill, he had a Pompe syndrome, and she said, not being able to feed your child is hard for many reasons, but as a mom, you miss that normal bonding experience you think you need to have. Mothers are supposed to feed their children, whether from breast or bottle. It is your main job when they are little. Food is needed for survival, and when you cannot provide that for them, you question if you can, as a mother, keep them alive at all. But she also added, food is a way to gather and feel part of the community. When your child cannot eat like others, it makes you feel isolated from that community and sometimes your child. So I just wanted to end, so bringing it all back, thinking about all those things I think that we think about parents and therapists need to think about together. We need to think broader than just the child eating the food. So thank you very much. And this is the little guy whose quote I told you.
Real quick, someone has misplaced this folder. The students from Rabat, I believe. If you know who you are, you left it outside, just come and see me, okay?
And you have 4 in the shoes. So again, Hello. Again, for the sake of the time, you can learn more about wonderful presenters from Spain. Enma, she always takes good care of us and the students when we go to Malaga, Spain. She always welcome us and give us a nice training for the student that we bring about what also OT about in Spain as well. And Aitor is also from Spain as well. So the floor is yours.
Thank you. Thank you, Said. Good morning, everyone. Before starting the presentation, I would like to ask you to close your eyes for a minute. Let's do an experiment. So, imagine yourself in a park. Imagine that you are having a walk. You look around and see some people pacing. You see kids playing, families having fun together. You can imagine the smells. Maybe it was raining yesterday. It's a bit cold. You imagine the colors of the vegetation, and you imagine the ground under your feet. You keep walking, and then you get to a square in the middle of the park and see a crowd. They are saying something, but you don't get to hear it well. But you look at their faces, you look how they are dressing, you imagine them, what can be they doing? So now open your eyes and be honest, please. Raise your hands, those of you who imagine someone with disabilities among the crowd. Well, this is why today we need to talk about in their shoes. Because if you, health professionals, OTs, have not registered in your subconscious mind functional diversity, what make us think that the rest of the world do? So for this presentation, we have three main objectives. The first one is identifying the need of using a transversal approach in the inclusion of people with disabilities. The second one is showing the power of experience-based learning when talking about inclusion. And the third one is understanding how international cooperation can work as a multiplier for a message around the world.
But actually we want to introduce ourselves a bit first. So we're representing here Asociación Juvenil Almenaras. And the aim of our entity mainly is to provide learning opportunities to the youth of our areas, but this is not what brought us here. What brought us here is our work in promoting the diversity. So this is our logo, and I want to speak about that. This is an almenara. It's a watchtower that the Arabic people brought to our land when they were there. But also we can see this eye, which is Phoenician eye, because the Phoenicians are the people who actually start our city, Malaga. So through this, we want to make that the people understand that we need to accept diversity because actually we have it inside. So it's not clever to don't accept it. So now, Almenaras became like a tool to promote diversity in a lot of actually field, but the most important I think is functional diversity, like promoting the inclusion in functional diversity. So we collaborate with a lot of institutions. IMA works in a lot of them. And this professional is working in a seed. This seed who is promoting diversity for disabled people has a name, and this name is In Their Shoes. So actually what is In Their Shoes? In Their Shoes is a brand of projects that we created, which the main aim is to train people from really different sectors about inclusion and diversity. We do it through Erasmus Plus program. It's a program that European Commission is funding and allow us to make experiences, about 1 week experiences, so we are able to bring people to Malaga, to our house, around this week, the last project we have 10 different countries. So we gathered together there, and through workshops based on non-formal education, we tried to give them shocking experiences and meaningful experiences to understand that nowadays in Europe, the situation of the people with disabilities is not really the best one. So they are going to be aware about the things that they are living and facing.
But why in their shoes? So have a look for a moment to this fragment from a test by the World Health Organization. If, as it is said, people with disabilities are among the most marginalized in the world, then I regret to tell you, but there's something that we are not doing well. Because governments are developing inefficient policies, because inclusion at schools is not real, because in Spain, a couple of months ago, a wheelchair user may not be able to take a train because it wasn't adapted. So something is wrong in the approach. We are failing, right? But the good news is that they say that these barriers can be overcome. And they even tell us how. Working together. Who? Governments, professionals, NGOs, people with disabilities and their families. But do you miss someone there? Because I do. If you have someone with disabilities at home, you are already aware. If you are a health professional, you work with people with disabilities and you get more inclusive. If you rule a state, well, you should at least think about inclusion. But what about the rest of the world? How do we dare, talking about inclusion, expecting citizens to become inclusive on their own? A transversal approach is essential so people with disabilities don't become disabled by society. So we need to raise awareness in every single one. We need to educate about inclusion, but we need to educate kids, teachers, shop assistants at local businesses, multinational owners, restoration professionals. We need to educate in inclusion, every single one.
So actually, as you can think, the participants that came to our project, they are not mostly professional in the health field, so we will not train them to make any kind of therapy. We want to train them to actually can make something in the environmental aspect. They come back home. So how we do it? We have these main points. So one in the most important one for me is raising empathy, because for us it's really easy to put ourselves in their shoes because we live with them the situations, but for those people that they don't live it really directly, it's more difficult. And we want the change. And there is no change without understanding, and there is no understanding without empathy. So when they came and we speak about barriers, the first thing that comes into our minds is the environmental barriers, the tangible ones. But we want to make them understand that those ones are just results or attitude and the lack of awareness and empathy that society have. And if we want to change outside, we first need to change inside of ourselves. And also we want to give them tools. Mostly our participants are youth workers, so they are working with youth, making kind of educational activity with them. So we wanted that then can include people with disabilities, young people with disabilities in their programs. So the most powerful tool that we have as OT is activity analysis for that. So we took it, we adapted, we simplified it a lot, but we made them aware that there is a way to understand the component of the activities, and we make understand that changing some components, they can make quite more activities more inclusive for a lot of different populations.
So, as Anderson stated, a key element of experience-based learning is that learners analyze their given activity to give it meaning from a prior experience. and it leads to further action. So that is the clue of the success of In Their Shoes, because our learners analyze this experience that we are providing them, which is really shocking and experience-based, and it leads to further action, the desired further action, which is the inclusion of people with disabilities. So within non-formal education, we created games, we created facilitations, we created activities, so they can feel the barriers that people with disabilities face in their daily lives. They can analyze activities while playing, they can adapt sports, which later they will perform by simulating functional diversity. And in this way, they are going to raise both their awareness and competencies. So they understand. And this experience really provokes a change in their attitude to people with disabilities, because both non-formal education and experience-based learning are meaningful for the learners.
So we have 1 minute, so we will go to the most interesting part, I think, which is this, dissemination, because what Erasmus, I don't know what happened. Okay, what Erasmus Plus program give us, because of course we make a lot of publication in our social media about the things that we do. Of course, we make things in the local, in our local community, but Erasmus has this magic that things that happen in one city in 1 week, they can be multiplied in different, just in the next week. So imagine that the thing that we did in June, they were multipliers in 10 countries just after that. As a sample, they are our Finnish participants that they were in this magazine speaking about what happened in Malaga. So this is the power of being of disseminating and to make visualization about, to increase the awareness actually. And we are closing now because they will.
So, thank you.
Thank you.
So here are 5, 6.
I was gonna say, there's a ramp, whatever you want.
Okay. I have two good news. One is our wonderful speakers, and the other one, after another presentation, we'll have a coffee break. Okay? All right. So our next speakers, Dr. Kali Lavin, who actually I had the pleasure of going. She was my also classmates when we were having the doctorate program at Boston University. So, and there she learned about our projects in OT in Morocco. And Dr. Sarah Collins also, and Dr. Kali, both actually bring students here and volunteer in Morocco for the last 2 years. So they will be presenting.
I'm actually only here because Kelly needs close supervision when presenting on stage. She has fallen off the stage multiple times.
Literally.
Yes, so
That's why I took the stairs. I'm not joking.
so it might be entertaining today. It will wake you guys up.
So I just want to say thank you very much. It really is an honor to be here in Morocco with all of you. What an amazing experience. We're going to shift it up a little bit, and we're talking about fieldwork education. And, you know, I think every presenter is sitting in the audience and doubting, you know, well, is my presentation appropriate, and who's my audience? And I've had a number of conversations with presenters just on this topic. And when I woke up this morning, I said, well, there's a number of students in the audience. So we're talking about fieldwork education.
And every one of them is going to take at least 10 students in the next 2 years, right? Or
How important that is by supervisors. And then, but wait a minute, I thought, I've taken students as a faculty member, as a program director. I am still supervising students. So it doesn't stop with the students. Our voice today isn't just for the students, it's for the faculty members in this room. It's for the educators. It's for the international presenters. We need to take supervised students. I have heard wonderful, wonderful voices since I've been here. You have such knowledge to share. You need to share it with our future generation. So we're going to show you, we're going to start off. This is a very short little clip that was put together by MOTEC, which is the Metropolitan Occupational Therapy Education Council of Fieldwork Educators, that Tara and I were co-chair for years. Sharon Sedlak has taken over my role and is now co-chair, a great organization of educators. And if I could figure out how to use a PC. Oh, no.
There's no internet.
Wait. It's going. Tech support. Okay. So what's the purpose of fieldwork education? According to the Commission on Education, it's to develop competent entry-level generalist occupational therapists and occupational therapy assistants. So basically, it's the purpose is to connect didactic education with practice, right? It really transitions us from student to clinician. Okay. I just want to go to that slide. So there are there are many different ways that fieldwork education models that it can come under. My experience as a fieldwork coordinator is everybody's comfortable with the first model, one-to-one. I have a student and I have a supervisor, and that is very traditional learning. I hear over and over from students, I need my supervisor to be with me all the time. I need to be in a hospital. I need to be in this very traditional setting. But we have come to, we know that fieldwork education can occur in many different settings and many different models. A 1-to-2 model, 1 supervisor and 2 students. And when we bring that up, that's important for all you potential supervisors out there. Don't take 1 student, take 2 students, take 5 students. Multiple sites, meaning if you are a clinician that works, we find ourselves working in many different facilities. A lot of times clinicians aren't just working at the hospital for 40 hours. I may work at the clinic for 10 hours here, I might work 5 hours there, I might do 10 hours of home visits. That doesn't mean you can't take a student. It does mean it's going to require a little bit of extra work on your part to get all those contracts and everybody's permission in place, but it is very doable and it is very rewarding. The group model and really the collaborative model and the peer model are all very similar. Basically, it's when a number of students are working together with one supervisor, and the ownership of learning is on the students. And that is really challenging for the students initially, but in my experience, it's where the student learns the most. So it's where the supervisor turns around to the student and says, what are your learning goals? What do you want to get out of this placement? Where do you see yourself in the next 5 years? And when students can welcome that and adjust to the change in mindset that I'm not going to be fed information, learning really occurs at a very fast pace. And when you process it at the end, it's really amazing. This is really one of the only models I'll use today. If I have a student, it's on a more collaborative model. I want that student, especially if now that I'm in academia, I'm very non-traditional setting. So you need to come to me with goals and tell me what you want out of this fieldwork placement. I just had a student over the summer, and it was the most amazing presentation that we could do. All right, we're gonna show you real quick our, it's not ready? We'll keep going. All right, your turn.
All right. As a fieldwork coordinator, we do not just look for people with a pulse as a supervisor. There are other qualities that we look for. So, there's some important things that we like the fieldwork educator to do. Be able to orient the student to the fieldwork site, lay down the rules. What are their expectations? What are their learning styles? How are they going to communicate with the student? What are the learning objectives? And just how are they going to create a opportunity to role model? So it's at MoTech we try to reach out to our sites and provide any kind of support to the new fieldwork educator or even a seasoned educator, just to really give them the materials and tools that they need to be a great supervisor.
Again, one of the only responsibilities, or one of the key things that we look for and we try to train our educators on, are in that ability to give and take feedback. It is extremely challenging to receive feedback. And it's very challenging for an educator to receive feedback. And to say to a supervisor, you have a pulse. Thank you for taking our students. Thank you for giving up your time and energy. But also thank you for allowing our student to provide you with the feedback of the experience, right? Because that's really important. That's how that educator is going to evolve. And it's important for the student to learn how to give that feedback, right? Not just to say, oh, this was great, and meanwhile, they really didn't get the experience that they needed. Apple's making a fortune. That's all I'm saying. Oh, this is you.
Oh, okay. So we collect, we're doing research on this topic, so we've collected some tools that are available for mostly free. We're going to talk a little bit about that now. Just go ahead. So Kelly's going to talk about the first one.
No, I think you are.
No, you're, yep.
Okay, sorry. So the Commission on Education through the United States, through the American Occupational Association, is a great resource for fieldwork education. Basically, it's a reference document that outlines various desired attributes of fieldwork settings to maximize student learning. There are guidelines, which are, at first, I always have supervisors and students asking if these are mandatory guidelines. They're not. They're just suggested, but they're very informative. And they're free to use, which is great because we're going to talk about the AOTA website, which is a great website, but not everything on there is free. So if you're not a member, you can't access it. But the COE document is free, And it also has links to other various documents that you can use for fieldwork education that are free. I got it. You what'd you do? There I was. There you are. So the American Occupational Therapy Association, if you're a member, everything is free to access. However, they do have a number of resources. There are guidelines for level 1 and level 2 fieldwork. The third is what I really love. They give you examples of site-specific objectives, because if you are in the United States and you have a fieldwork program, each site has to have its own unique fieldwork objectives that are relative to that site. That is a collaboration between the fieldwork, the school, the institution, and the site. And that's a tremendous undertaking. So this gives us a really nice backbone you can kind of tap into and modify as you need it. And tons and tons of resources for students, including what do I do if I'm in a situation that may not be safe, or I'm with a supervisor that's not hearing what I need her or him to hear. That's not really optimal for learning, because on rare occasions, those types of things happen. And you can access resources here that really will lay out step by step the process of how to handle those difficult situations that are difficult to navigate. The SafeCom, you can also access for free through AOTA. Is that you? Yeah, go ahead. It's a free tool. It's there to help develop fieldwork educator professional education. 5 main areas: professional practice, education, supervision, education, and administration. We're going to go fast because we have 5 minutes, and I really want to show you my video.
Oh, the AOTA workshop. It is a little costly, but it is a great workshop for someone that really wants to jump in as a fieldwork educator. It covers 4 areas: administration, education, supervision, and evaluation. It's usually a 2-day training. I know our consortium in New York tries to put on 1 course a year, and we invite our fieldwork supervisors in the area to attend for free. We cover the cost. So it's just a great way to kind of get more supervisors. The Queensland. The Queensland is another free tool developed in Queensland, and basically there is there's videos on the website and lots of materials for you to use. There's 4 topics include pre-placement considerations for student clinical education, setting up and sustaining a positive student clinical placements, approaches to clinical education, the feedback process and evaluation, and working with students who are experiencing difficulty. The FEAT. Okay, the FEAT is another free tool. It is located on the AOTA website, and it provides feedback to the supervisor. Do you want to say anything else about the FEAT?
No, but the one thing, I'm sorry, we're all discombobulated, trying to get. I'm going to go into the last one because I think this one is a great one. It's the Preceptor Education Program for Health Professionals and Students. It is the PEP, and it is an amazing resource for healthcare providers. It's not specific for OT, but I have used it over and over with my fieldwork educators. I've taken each of the 9 modules myself. Depending on what your accreditation body is, or your, like ours is not our accreditation body, your continuing in the United States, NBCOT, to be a member, I have to show continued competency. And I can use the certificates of participation of these 9 modules towards that continuing ed. So if you have, we also, our states mandate continuing ed. So if in my state, I could also use this for it. But the modules are a self-paced, they're interactive learning, and at the end of each module, like I said, you get a certificate of completion. So I've used it when I've had a student struggling at a fieldwork site for maybe on professional behaviors, and they just didn't have the insight. And after the modules, it really, they're great education tools. It gives a lot of good examples on professional behavior and how to deal with those situations.
Okay, our references, but we're going to go back to the beginning. Let's see if we can get this video going. Come on.
Okay, so we're going to hand over the mic because I know time is of an issue, but maybe during the coffee break we could try the internet, and maybe Saeed would give me 2 minutes when we come back. See, we didn't even have to get thrown off the stage.
Yeah. But she might fall off the stage, right?
Yeah, can you hold her hand, please? Can you hold her hand? All right. Okay. محمد فين هو محمد؟ If you do have a video in your presentation, we are not supposed to use the internet of the computer because of virus and other things popping here. So you can have it in USB and we can show it, okay? So, all right. We have the pleasure to have Dr. Mariam Fortasi, who is a physiatrist and one of the earliest supporters of occupational therapy in Morocco. Dr. Fortasi, she is the head of the rehabilitation program at the CHU in Wajda Medical School, and she will be sharing with us her presentation shortly.
Okay. Thank you, Saeed. Assalamu alaikum. Hello, everyone. It's always a pleasure to be here with all of those really beautiful people to share some words with you about our experience. Well, Saeed asked me to talk about the daily occupational challenges facing medical students because he knows I'm very interested in medical education. I am a physiatrist at the head of Department of Rehabilitation in the University Hospital of Oujda, but I'm also very, very interested in medical education as a whole. And I do a lot of work with students, and I conduct a lot of research about medical education, the current situation, the challenges, and what we need to do to improve medical education in Morocco. So I thought that it's always challenging to talk at the end of a session, especially just before a coffee break. So people are not maybe very concentrated. So I will try to make it more interactive and short with not a lot of words, mainly pictures. This is a picture of the Faculty of Medicine in Oujda, where I teach as a medical professor in medicine. And what do you think are the challenges of medical students once they set their foot in the medical school? What's the main thing that changes when, for example, yesterday you were a student in high school, and the day after that you were a medical student, freshman? What's the main change? Who's not there anymore? Yeah, parents are not there. So we can do whatever we want, or that what we think we can do. Wake up late, okay? There are no calls at 8 o'clock by the teacher, who's there, who's not there. So you can go or you cannot go, not attend courses. It's not mandatory. So you think you can wake up late. That's what a lot of students do at their first year. What else? What can they do? They're free. No parents' guidance, no limitations. Of course. Well, yeah, it's not working. Okay, here, yes, we go party, do a lot of stuff. Now we can do whatever we want, and a lot of romance. Now that we are adults, and no problem, we can go hiking, we can do whatever we want to do. So those don't really look like challenges. Of course, parents are not there, we are free. But what is the other facet of the situation? Parents are not there, what does it mean? We're by ourselves, which means messy apartment. And here, for those who work in occupational therapy, see where the interest is. Empty fridge, okay? No one to go do your shopping for you, so you gotta shop for your food. And not only shop for your food, you need to cook it, and then to do the dishes after you cook. And what else? You have a lot of dirty laundry, a lot of stuff to take care of, and that's only what happens inside the apartment or where you live. And if you have co-location, if you live with someone else, it's complicated because you don't always know the people. And all of this is part of the occupational challenges you'll get to deal with. Well, now, this at home. What happens at the university? I mean, what are the changes from being a student at high school and then at university? First of all, we as professors are always frustrated in front of the very poor attendance. Well, my courses are always full. No, yeah, they're all there because I make it interesting. But most of the time, the attendance is poor because it's not mandatory, so students just don't go, and they don't see where the problem is. Then, of course, when you are a medical student, it's a new occupational setting, a new learning environment. You gotta go to hospitals, you have rounds, you have professors, you have doctors teaching you stuff, and of course, who can be mean often in a lot of situations, and that's very challenging for students. And then the exam comes really quickly, and what happens? You start staying up late at night, trying to make it up for all the time lost in partying and in romance and in doing whatever you wanted to do. And of course, most of students do not have a strategy to deal with lessons or to deal with revisions at university because it's different from high school. You don't have a calendar, you don't have clear guidance, you don't have objectives. And here I'm talking about Morocco. I know that maybe elsewhere in Australia, in the United States, in UK, it may be different because you have short classes. Here in Morocco, medical students, they just have, they're basically taught in lectures. 90% of the teaching is based on lectures, and they have no guidance at all. They only have the lectures calendar and then the date of the exam. So they had to do it by themselves. Why is it important? Why are those challenges important? Because they have consequences. And we ran studies where we made sure the consequences are not, they are really important. We made a survey. It was a national survey. And we realized on medical students in Morocco, and that's a population of around 14,000. The survey covered 2,500 people. And we could have as a result that 57% of medical students do not finish their studies on a limited duration. Like 4 out of 10 they will graduate after 7 years, and that's what's supposed to be. But 6 out of them will go to 8 years and beyond because they will have to retake years, okay? And that's very surprising because in Morocco, medical studies are very selective. You don't get there unless you have a high grade in high school, and then you need to pass the entrance exam, and it's very, very selective. Only the top of their classes make it to the medical school, and then 57% will have to retake years, which has a lot of consequences, both on the individuals and their families. You have people, the families will have to pay around 20,000 dirhams, which around $2,000 a year for living expenses. And then we have an increase of depression risk that is multiplied by 12-fold. And that's proven by studies. And then we have consequences, economic consequences on the society, because medical studies in Morocco are for free for people who can get there. They don't pay for the studies, so the government pays. And the cost is around 130,000 dirhams a year per student. So each year retaken per student will cost the society that much. So we conducted a retrospective study on all the students that went to the Faculty of Medicine I work in, and we looked to their files to get all the information we could get, both on their demographics and life conditions, because students have to fill a form each year saying if their parents live with them, not with them, if they suffer from disability, and a lot of stuff. And then I looked to their academic performance and tried to find correlations, just to tell you that what we found is that the failure rate when students need they have to retake years, it's 3 times as frequent in the first 2 years than later, which means it happens in the transition from, okay, I'm almost done. It happens in the transition phase, in the phase where you have a lot of occupational challenges to take care of, among other problems. And then we looked to the factors that influence this failure rate. I'm sorry it's in French, but here just to tell you that for students whose parents live not in the same city, for students who live by themselves because they had to come from another city to Oujda to study in medicine, there is a significant relationship with failure. If you live by yourself for the first 2 years in medicine, you have higher failure rate. So those occupational challenges are really important. Now, how can we deal with them? Because part of my presentation is about giving strategies, and I think that 4 minutes that I have now won't be enough to do that, but I will share with you the idea of a project I'm leading that needs or that aims to help students, medical students in Morocco and maybe in Africa later, to be empowered and to better face their challenges. And that project was launched only on the 1st of January 2020. It's very new, and it's called Qasam. Qasam means in Arabic pledge, and it represents the doctor's pledge that we take at the end of the years. And our vision is to help those students, the day they will give their pledge, to be able to be up to it. And this comprehenses a lot of aspects we need to help them to succeed in. For example, their hard skills, and that's mainly what medical universities in Morocco provide the students, only hard skills, what they need to know to be doctors, competent. And then the soft skills that are really very overlooked in our universities. We're not taught anything about communication, but very little about communication, empathy, and other soft skills. And then I focus a lot on study skills because you don't have the strategies when you come to university, and we are here as a team of Qasam to give you the strategies, to put you in contact with senior students. We did a lot of mentoring, virtual mentoring through WhatsApp, through Facebook, putting people together and helping them, making students help each other. And then those support groups that are focused both on studying skills, but also on psychological support. People who failed before can help those who are failing now to surpass their failure. And then the guidance for the choices of if you want to stay a general practitioner, if you want to pursue a specialty or things like that, what are the best ways if you want to go study abroad, how to do that, and then research, because I'm an academician, and this is one of the important parts of my job, is to conduct research and to try to use all the information we're gathering to prove things. And to finish, I just want to show you a 1 minute and 22 seconds video that was the trailer of launching Qasam, and it represents a student, it's in Arabic, I'm sorry about the volume, I couldn't insert subtitles, but what she's saying are the verses of the pledge in Arabic.
في هذه اللحظة التي يتم فيها قبولي عضوة في المهنة الطبية، أتعهد علانية بأن أكرس حياتي لخدمة الإنسانية، أن أمارس مهنتي بوازع من ضميري وشرفي، جاعلا صحة مريضي هدفي الأول، أن أحترم أساتذتي وأعترف لهم بالجميل الذي يستحقونه، أن أقوم بواجبي نحو مرضاي بدون أي اعتبار ديني أو وطني أو عرقي أو اجتماعي، أن أحافظ بكل حزم على احترام الحياة الإنسانية منذ نشأتها، أن أحافظ بكل ما لدي من وسائل على الشرف والتقاليد النبيلة لمهنة الطب، ألا أفشي الأسرار المعهودة إلي، ألا أستعمل معلوماتي الطبية بطريقة تضر بحقوق الإنسان مهما لاقيت من تهديد، أن أعتبر سائر الأطباء إخوة لي، أن أهتم بصحتي الجسدية والنفسية، وأن أنمي معلوماتي وأطور مهاراتي من أجل توفير الرعاية لمرضاي على أعلى مستوى. بكل هذا أتعهد عن كامل اختيار ومقسمة بالله، والله على ما أقول شهيد.
I'm done. Have a nice coffee break, everybody.
Okay, it's time for coffee, but before you move, I would like to have the speakers and the honorary guests to follow Mr. Brahimi and Mr. Murad to the room there on the left for the coffee break. And so the speakers and honor award, Dr. Hlu and Ayub. And so the guests and the students, you are welcome for coffee and tea here.
let's wait, we gotta wait for them. We're gonna just be quick. We have to wait for, what's her name? You know who I'm talking about? No. Where the heck is she? Come on. Yeah, we're just waiting. Yeah, they'll be fine.
Please sit down, get your seats. We're gonna start in 1 minute.
Should we tell them outside?
Yes, I know.
We should tell people outside.
Yeah.
All right. We are going to show the 1 minute video that we can watch before, and then we'll continue, okay?
Wait, we're waiting for someone to come in.
We just want Wendy to see the poster, the thing. She'll be here.
Somebody has to go get they are in this,
Go
Want me to run?
Go run and get
Tell
everybody to come in.
yeah,
Go tell
in
her.
the big room. Speaker room.
I don't know, Monique just went to that room. Oh, okay. And we're not allowed to. Yeah. So that's Wendy. Hurry, Tara. Yeah.
With her? With Wendy?
Oh, okay. All right, we'll wait for Saeed and then we'll start it.
You can start with Adam, right?
Yeah, well.
Where is he?
So we're gonna just show you that quick little video that we were so excited about.
Is our profession in trouble? It will be if we don't have enough sites to take our students for field work. Fieldwork coordinators face the same responses day in, day out.
Sorry, our census is low.
No, our space is too small.
No, we have several staff members who will be on vacation.
As we are all aware, there continues to be a national fieldwork shortage, and we are doing all we can to ensure you will have the clinical experiences you require to successfully practice in the field of OT.
Discover the superhero in you. Become a clinical supervisor and give back to the OT profession. It's your turn now. Consider this. Students can energize and motivate us in new ways. Students bring the latest research and AOTA initiatives. Students sharpen our supervisory skills. Taking a student for field work keeps the profession alive and thriving. The life and longevity of our profession lies within your superpower. Say yes and take a student now. contact your local academic fieldwork coordinator today and they will help you with the process. Brought to you by the Metropolitan Occupational Therapy Council of New York and New Jersey.
Woohoo! Take a fieldwork student today. Yeah, we'll come to Lebanon. I sent a student to Egypt. It's one of my proudest moments. So you can do international. Okay, I'm going to get out of here.
I'm going to send you a contract.
Okay, so come up in there. So, thank you.
We are. Which one? Because you know it's so many. Elizabeth? Where is she? Because I'm looking for one. Let's hear this panel, 3 of them. I don't know which one the most good. That's okay. No, it's here. Just panel. Yeah, which one? There's 3 of them. Okay.
I don't think this is the one. I see. Okay, here. We do.
The Morocco one? No, with the Morocco one. Which one? You understand? Yeah, no problem. Okay. Welcome back. I hope you have now enough energy after the coffee and the tea and the cookies. So we'll be starting with our panel presentation, where we will be discussing the current status of the occupational therapy in the Arab world. And we are so honored to have some of the pioneer occupational therapists in the Arab world with us. And also some of the countries, especially with Jordan experience, who was one of the earliest countries in the Arab world to start occupational therapy. And we'll start with Dr. Hashim, who will share with us the OT experience in Jordan.
Bismillah ar-Rahman ar-Rahim. Thank you all for being here. Thank you, Saeed, for making this happening and for organizing all this event and giving us the opportunity to participate in this conference. So we're going to cover the occupational therapy in the Arab world that started fairly recent. I'm going to talk about Jordan and about Kuwait, then I will give the stage to my colleagues to talk about each country. How this works? Can I have the pointer? Okay, so I'm gonna talk about Jordan, and my name is Hashim. I'm an associate professor of occupational therapy from the Hashimat University. So in Jordan, we started occupational therapy early 80s in the service level. We didn't have OT at all that time. 4, I believe, therapists came from Sweden, and they started OT services in the Royal Medical Services. It's like a military-based hospital. After that, we started, or physicians or the medical models started to see the value of OT. This is when they decided to establish the first diploma program in OT. The diploma is like 2 to 3 years. And the program was started or established in 1989 until 1996. They graduated a total of 50 of that. After that, in 1999, this program was closed, and we started the 3 OT programs that they are still running until this moment at 3 governmental universities: the Hashemite University, the University of Jordan, and Jordan University of Science and Technology. And the good thing is all of our programs are WOFIT approved. I have some statistics about that. The Hashemite University, where I belong, we have total number of graduates, as you can see here, since 2002 until 2018. We have a total of 451 graduates. Majority of them were from Jordanians. The 17 of them were from the Gulf area. Female, we have 78% of our graduates were female. And this university is in the east. The Hashemite University is in the east of Jordan. University of Jordan is in Amman. The capital of Jordan is like in the center of Jordan. We have a total of 342 graduates. Majority of them were from Jordanians, and 88% of female graduates. The third university is the the Jordan University of Science and Technology. A total number of 520, but like almost 50% of them non-Jordanians, and a total female of 69%. So from the 3 programs, total number of graduates is 1,300 around, and Jordanians around 1,000, which makes the female 77% of our graduates were from females. The practice issues that we have over there is, in Jordan mainly, the limited number of senior occupational therapists. Okay, we started graduating graduates since early 2000. The problem, once our students graduate, they will have a couple of years of experience, and this is their ticket to go to the Gulf area to work because of the better salary. So we are left out with only junior therapists until now. So our seniors, they are working outside Jordan. We conducted a study along with Dr. Razan, and we found out about job situation in Jordan among OTs. They are low paid, unfortunately, less than 300 Jordan dinar, around $500. Most occupational therapists work in private rehab centers. However, those private rehab centers, they are owned and managed by special educators. So they have their approach like dominating rehabilitation setting in the private sector. We only have limited number of hospitals that have OT departments. Just imagine that we have in Jordan 33 governmental hospitals, and among those, only less than 5 hospitals have OT departments. And even the OT department, like for example, Al-Bashir Hospital is the largest hospital in Amman in Jordan, and it has only 2 occupational therapists. So this is another struggle that we have. And another thing was the lack of awareness about OT among health team members. We conducted another study to measure the knowledge among health team members about OT, to find that physicians were the least to know about occupational therapy. Well, if they don't know about occupational therapy, how they are going to refer patients for us? So this is another thing for us to do, is to increase awareness about OT. And the last thing, increasing number of graduates and limited number of job openings. Out of the 3 programs, unfortunately, for the last few years, they start to accept more and more number of students. This means that we're going to have an employment rate among, is going to be more and more in the coming few years. So that's what we can see. So these are the practice issues that we are facing. I'm going to talk also about Kuwait. I contacted my friend, Dr. Nasser Al-Otaibi, and I'm going to present about Kuwait on behalf of him. So, sure, come over. And I'll come back because she's going to talk about the opportunities.
All right. Hello, everyone. Marhaba. للكل موجودين. My name is Dr. Ruzan Hamid. I'm an associate professor at Columbia University. I'm so happy to be here because I like to see this cultural collage. There's a lot of you here, and it's amazing to be among you. Thank you, Saeed, for making this happen, although we'll talk about the hotel, but it's really good to be here. Okay, talk a lot about a lot of things. To continue talking about Jordan, so I really like that we have OT students here. Any Moroccan OT students? طلاب مغاربة. There you go. So there's a few of you, and I really can relate to your experience. I graduated. I'm one of the first batch. I'm actually the very first batch of occupational therapy in the Middle East, and coming from the University of Jordan, the best, of course. So I understand your experience. I understand there's a lot of challenges, particularly for your batch, because there's still a lot of things to figure out. Field work was an issue, education, all of the challenges that we're talking about before biomedical students, you have that and more. And also the pain of explaining what occupational therapy is over and over and over. So I can relate to that, and I'll be here if you have any questions about how we managed it as first batch. So continuing, we are still at the bachelor level for education-wise. And there's a lot of reasons for that. One of it is we're still very new as a profession in the country. There's a lot to do. And also, culturally, I don't think we are ready to accept the master's level being an entry level for a lot of logistics reasons and financial as well. So that's the level-wise, entry level. Accreditation, we have 2 levels of accreditation. The first one is local, and it's similar to that to the American system. We have the Department of Education that approves all educational programs, and we have a commission similar to ACOT in the US that approves the OT specific programs and requirements. It's a very rigorous and painful process because I served at that end too, developing curricula and working with syllabi and accreditors. So it's a really rigorous process. And we also have the WFIT accreditation, which is also another systematic and rigorous process. So this is good news that we have both of them in Jordan. Field work, and again, this will sound familiar. This is the growing pains of everybody. There's always limited spaces for field work. It's more so in Jordan for a lot of reasons. First of all, the healthcare system in Jordan is extremely complicated, and it takes ages to make any kind of change. So let's say there's a lot of emerging areas of practice that you can send fieldwork students to. These places are not ready to take students because, first of all, they still understanding what occupational therapy is and the level of services they can provide. So limited space in hospitals, and they mainly are hospital-based settings. We have to have all kind of settings, of course, to meet the accreditation. So we do have mental health field work. It's very similar to the American standards, where you have mental health field work, pediatrics, physical dysfunction, and they're all mandatory. And we meet the hours and more. But again, people are not, as Dr. Hashim said, having a senior therapist is a challenge. So most of our students, in my batch, we were supervised by senior occupational therapists from other countries like Iran, Egypt, but they were not even trained in these countries. So again, it was a challenge finding an occupational therapy supervisor to supervise field work too, specifically. 1 minute? Okay. I'm ignoring you. New graduates have also a lot of challenges, especially when it comes to applying theory that we see in class and assessment tools that were originally developed for Western countries to take it back to Jordan. Jordan is an Arabic, Muslim-based, conservative community, and we take all of these assessment tools and textbooks and theories and models and frameworks, and we apply and we tell the students, here you go, this is the ideal, this is the gold standard, now you take it, figure it out. We don't actually throw them to figure it out, but the idea is try to be creative and understand like how to do that. So this is a huge problem for our students. They see all of these things and then there's no way to implement them. So we had to come up to adapt all of assessment tools. We had to translate assessment tools, but we still have a lot of work. They have still a lot of work to do, developing new assessment tools as well. Evidence-based practice, again, is a very common problem. Because of all the, the set of challenges, time, money, people don't even know how to access an article. The research knowledge given is not enough. We have licensure by registration, meaning once you graduate, you register with the Jordanian Association of Occupational Therapy. And again, they also have to go through your credentials and diploma. They have to validate that it's original, etc. And then you are licensed. We still don't have a board certification. This is something for the future, I guess, an opportunity. We have an extreme shortage in educators that are PhD trained. All of the faculty members, and I mean each one of them, studied in the US or the UK or Australia or Canada or we have no universities in the Middle East that can give any kind of degree that would qualify faculty members to teach in an occupational therapy program. Because also the Department of Education are very strict in making sure that your credentials are consistent with whatever you're teaching. So we have a lot of obstacles borrowing people to teach in our programs. We still need a lot of public education to do. People still don't know what occupational therapy is. I remember the first time I told my father that I want to go for OT. It's like, what is that? And I explained that. It's like, no, you're not massaging nobody. And he's still telling wrong stories about me. Opportunities, we're hoping that we get to, they're hoping, I keep saying, what? No, go away. I'm still, all right, fine. Thank you.
This is Kuwait now. Hi again. So, yeah, okay. So in Kuwait, similar to Jordan, at the service level, they started early 80s. They brought clinicians from India and from Philippines. Once they started to touch the value of OT, they sent 4 of our colleagues that we know, our friends, Musa'ad al-Nasr, Nasr al-Atabi, Muhammad Nadar, and Fahad Mani'. They sent them to the USA to have their bachelor and master's degree. So in the 90s, they came back, those 4, and they started working in different sectors as clinicians. And then they said, okay, let's open a program in Kuwait University. So they sent them again to have their higher education. Musa'ad al-Nasr, he finished his PhD with me, and he came back along with Muhammad Nadar. In 2006 to 2008, they built their curriculum. And they brought Professor Prentnell from Canada to help them with the program. Their program is WIFIT approved as well. It's not moving. Oh, no. Oh. Okay. They accepted the first batch of students 2009. Nasr al-Atabi told me that they already graduated 8 batches. Size of each batch or cohort about 20 to 27. They have more than 100 graduates, and they have a plan now to start to establish their master program in occupational therapy, which is, I think, great news for the area. Thank you very much.
Lebanon?
All right.
Good morning. My name is Dr. Fatima Shohori Nasser. I'm the president of the Lebanese Occupational Therapy Syndicate. It used to be the association. Now we have a syndicate. So I'm going to try to be very quick. The program really has been, or OT has been around for quite some time, for over 20 years. But, and we've come a long way, although we're still, I believe, in the beginning stages because we have a lot more work to do. So on the slide, I briefly said that we started in 1997 at the Lebanese University, which is around the same time that I started coming from the US, because opposite of some of my colleagues, I was born in Lebanon, but went to the US because we immigrated and did my studies for OT in the States. So then I came back to Lebanon so I can start this beautiful profession in my home country. So the program was already in place back at that time, and they started through a French organization, and this is how the actual program started. So it's a program in French. Now, there's another second program. This is how the development is taking place, which is really wonderful, that although the Lebanese University is a public university, now we have the OT program that's also using the French curriculum, starting in a private university, which is the St. Joseph. So this is going to be, I think it's a step forward. Both programs are at the bachelor's level at this point. The OT Association started back in 2003, and we just became a syndicate. And when I say a syndicate, it means that we have more of a value and weight in terms of legalization of the profession, which is, this is what you need in terms of stepping forward and bringing the standards of practice to a higher level. And this is really what I'm hoping for. So our syndicate is an associate member of WFOT. However, the programs are not accredited yet. And I've been working all these years to get this, the program at the Lebanese University, because this is our national university, to have accreditation. That has not happened yet, unfortunately. So, but we're hoping that we move in that step. Okay, next. Is this the? Okay, no, sorry. Oh. Okay. The challenges are pretty much like my colleagues, and you're going to hear, they're going to be about the same, very similar challenges, I think, when you talk about occupational therapy in the Arab region. OT is not covered by insurance, so that's going to be a very, very step backwards, right? So most of our clients pay out of pocket. So if you're going to pay out of pocket, you cannot sustain therapy. Right, so we're working on that as well from a legal aspect. But as you can imagine, Lebanon has been struggling with a lot of different kinds of wars and instabilities. So that poses, I think, a different kind of issue when it comes to insurance coverage. The programs are not accredited by WFOT, although we're working on that. But until we get accreditation, I think that's also, again, it's a big challenge. I think, like a lot of my colleagues, the governmental support is not there, so you have to prove over and over again, talk to a lot of politicians about the importance of why OT is just as important as PT, with all my respect to my colleagues in physical therapy, but they think that, like, we are second-class citizens. But believe me, I'm working very hard on changing that. And the proof is in the quality of work that we do as occupational therapists throughout of Lebanon. And that has been proven, and it's really, our therapists have done a great job. The standards of practice, I mentioned that. I know some of my friends might not like this phrase that I put, that there's a difference between English and French standards. So Lebanon does not use any of the American or English standards of practice. Not to say that the French is not a good quality. However, the cultural and the standardization of practice really differs. I'm speaking this from experience of knowing the programs and the curriculums that exist. And I think unless we change that in Lebanon, it's going to be a little bit more challenging still. So this is something maybe for AOTA to help, Lebanon along those ways. We'll see. I'm very hopeful. I'm very hopeful. I'm an American OT practicing in Lebanon. So anyway, also, we have limited clinical places for our students. So a lot of them go to rehabilitation centers. Like someone said, I don't know if Dr. Razan, maybe about placements in hospitals. So it's like almost non-existent in hospitals, and that's really a shame because we know the added value that we can give as OTs in hospitals. Also the education level of OTs, they're all at the bachelor's level, and unfortunately they cannot move past that because we don't have programs that can allow them to get a master's level unless they go to the US or another country, and then they have to start all over again because we're not accredited. A lot of the graduates from the Lebanese university, they have gotten degrees, like a master's degree in rehabilitation science or some other in health sciences, and so that's what they've been doing. We're hoping that eventually with the St. Joseph's University, they're talking about having a master's level program of OT education. So that would allow our students that graduated from the Lebanese University to be able to get a master's in OT. But this is still, it's gonna take time. Research. There's very limited opportunities to do research. If they don't have, there's the OTs who are graduating, they're wonderful. They work a lot on themselves to gain more knowledge and to improve their practice skills. But you know what? They're too busy with that to be able to think about research at this point, right? And research takes a lot. But this is what we need to raise the level of OT in Lebanon. Thank you. How did I do with time? Good? Palestine?
There you go.
I am. You want me to continue?
Slide, right?
Sorry. Let me see if it's the other. Okay. It's a quick slide. Okay. All right. So I was asked to talk about OT in Palestine. And which I didn't know anything about it, honestly, and apparently they have great programs. And so this is the information I got it from Dr. Musa Abu Mustafa. So apparently they have about 600 OTs in Palestine. Their level of education varies between, they have a lot of OTs who have PhD level, master, bachelor's, and 2-year diploma. They have about 300 registered, so they're like half of them are registered within their association because they have an association. The other half they're not registered. I think this is also, it's an issue across the board. I know for Lebanon, not all OTs are registered within the syndicate. So now the distribution, primarily also split 50-50, so 300 work in Gaza and 300 work in the West Bank. Employment rate is very high. They're always, according to what Dr. Musa told me, it's hardly finding someone who has a degree in OT that doesn't find a job, which is great. And they're always looking actually for OTs. Their challenges, low awareness about OT in the health disciplines and in general, just like I think most of the Arab countries, we find the same issues. A lack of resources in academia. So I think because of the location of where, the issues with the locality of Gaza and the West Bank, to have some of the Arab OTs to cross the border and work in these areas. Perhaps that's one of the issues. Also, to find laboratories that are well equipped. I know that's what Dr. Musa was saying. So they don't have a lot of money that can back them up to have the latest in technology and so on. Lack of resources in clinical settings as well, such as splinting, and again, with having the accessibility of the materials. They have limited job opportunities in governmental sector, especially in Gaza. So a lot of the OTs apparently they work in rehab centers, okay, and then there are limited participation in national and global OT events. And this is something that I think we need to do something about that, to get our colleagues from Palestine to participate, because I asked Dr. Musa, like, what do you do? We never see you guys, so it'd be nice to have them join us at a certain degree, inshallah. Okay? Yeah, thank you.
So it's before that? Okay, I'm ready. Good morning, everyone. Can you hear me? Okay, excellent. So my name is Dr. Bazan Mubarak. I'm a consultant occupational therapist working at one of the biggest rehabilitation facilities in Riyadh, Saudi Arabia, and also CARF accredited facility. Today, I'm just going to give you a very brief overview about the OT practice in Saudi Arabia, which has started about 24 years ago, not so long. When it was first started, the majority of our OTs were international, with the majority from the UK, Australia, South African, India, Philippines, and also Jordan and Palestine. According to the Saudi Arabian Ministry of Health statistics 1997, less than 35% of our OTs in Saudi are Saudi, which is not a great percentage. It is estimated that this range has increased, especially after the establishment of the OT program in our universities. With regards to the challenges and opportunities for OT practice in Saudi, in a study by Al-Gurney 2007, when examining the feasibility and effectiveness of related services for students with mental retardation in our public schools, it was found that OT services are lacking in schools. Another research study by Al-Gurney, also 2010, attributed this lack of services due to the OT preference. What he said that OTs in Saudi prefer to work in hospitals rather than schools, which may create working opportunity for our new graduates in schools. A different study on stroke rehabilitation conducted in 2016 documented that rehabilitation professionals in Saudi were not well trained to manage patients with stroke. Unfortunately, that was found. And it was suggested that specialized program should be conducted, post-professional programs, which creates more opportunities. It was also recommended that the development of stroke-related outcome measures should be established by our OTs in Saudi. You all know that some of the outcome measures that we're using in our Arab countries are not culture appropriate, so we need to work on that still. And going back to the specializations, at King Fahd Medical City where I work, we are moving now towards specialization because now it is program-based. We have brain injury program, we have stroke program, and recently we will be establishing the amputation program. So we are looking forward to recruit those specialized OTs. And also we started to send people abroad to be specialized. So that again creates a big opportunity for our future OTs, I would say. That's all from my side. I tried to keep it so brief. If you want to learn more about the OT practice in Saudi, please see me during the break. Thank you very much for your attention.
Oh, that one. Okay. Hi, everyone. I think I'm the last one, so I can take my time. I'm Dr. Hadi al-Bakhsh. I'm assistant professor at Princess Noor University in Riyadh, and also the vice president of the Saudi Occupational Therapy Association. I'm going to try and make this brief as possible. I'm going to give a quick overview of the education of occupational therapy in Saudi. It relatively started recently, so around 2011, 2012. At that time, I was doing my PhD. It started with 3 universities. These 3 universities, they adopted 3 different programs. Princess Noura, where I teach, we adopted the Australian program from Monash University. So we had a contract with them for 5 years where they gave us, like we bought the curriculum, we did the adaptation to it, and we had 50% of our staff is from Australia, actually coming for the 5 years. King Saud University, they made up their own curriculum. King Saud for Health Sciences, where Dr. Hashim worked, their program is from Oklahoma University. And obviously they did the adaptation. So we do have currently OT bachelor level degree at 4 public universities, 3 of which they are in the capital city. And the other 2, one is a private university in Jeddah in the Western Province, and one public university. Of all of these programs, 2 of them only are WFIT accredited. And this is because it's recently established, obviously, the requirements for the WFIT to have faculty, OT faculty members, and so on, and even the head of the department to be an OT. That kind of made it difficult. We do have a Saudi Occupational Therapy Association, which is a full member in the WFIT, and it started 2013. And now we're starting to do more activities in the association because we have a large number of graduates. I can give a rough estimate on the number of students that we have who are registered in the association. That at the moment is 300 students. And in terms of professional, I think a professional registered in the association, that's 60. So, and the number is growing. We're trying to reach out for everyone to actually ask them to register so we have a better count. Because if you go to the WFIT website and look into Saudi and the statistics there, it's not accurate. So it's actually we have much more people within the association. Now the challenges, as everyone said, it's a new profession, we don't have the expertise. But for us, mainly the faculty members. We don't have enough faculty members. We have a lot of programs. And just to give a rough estimate of the population of Saudi, we're 30 million in Saudi with 8 or 9 million in the capital, Riyadh. So that's why we have a lot of programs. We will always be in need of OT, and we're still not filling the gaps. But we don't have enough faculty. A lot of the faculty members actually are on scholarships at the moment. So from my department, we have already 3. They're getting their master's and PhD, so it takes a long time for them to come back and work. Some of them, they come back and work like Bezza in clinic. And so the way they work is a little bit different. We don't have mentors, so senior mentors. Because either they're away or they have other responsibilities in clinics. So the juniors kind of don't get the mentoring one-to-one in terms of their skills, improving their skills. Training facilities. We struggle with the placements, the fieldwork placements, because we have a lot of universities. So if you think about it, 3 universities, they have a certain amount of hospitals or field workplaces, and everyone is first come, first serve kind of thing. So we often we struggle to, please just take our students, and we have to do it a year in advance almost. So that's one of the main issues. But in my university, Princess Noura, we're trying to look for other unconventional places for practice. So that includes schools. We're including associations for breast cancer survivors and so on, mental health. So mental health now is becoming new, and the stigma behind working at mental health is being reduced. Graduate and postgraduate degrees, at the moment we don't have any. Mainly the government encourage higher education to be done abroad. That's why any faculty member, once they get hired, we encourage them to go and do their all degrees, master's and PhD, and come back. But there's a new direction which is, as Baza mentioned, the specialization. And actually, we're trying to do this in collaboration with the rehabilitation hospital, where we can look into opening either higher diplomas or residencies or fellowships. But again, one of the difficulties, okay, which specialty shall we start with? Who are the mentoring? Who gonna oversees this? So the collaboration came actually last month, where the hospital and the university gonna come hand in hand and establish these programs. So this is a rough idea, very quick. There's a lot to be said, but I'm not going to take time. So thank you all for coming, and thank you, Saeed, for inviting us and allowing us to share this. Thank you.
So we'll talk a little bit about the Moroccan experience in occupational therapy. نهضر بالعربية والإنجليزية. شحال من واحد كان عارف شنو العلاج الوظيفي قبل هذا الكونغري هذا؟ شحال من واحد؟ How many people know what occupational therapy is? From Morocco, what occupational therapy is? Huh? So, well, a lot of people, okay. But a lot of people do not as well. So, occupational therapy started in Morocco, in fact, way earlier than what we all know, but it was very short, a brief experience. It was through a program through WHO and World Health Organization and the United Nations. In 1959, there was a major health disaster here in Morocco where a lot of people got poisoned by oil poisoning, that they consumed some oil was not to be consumed, and a lot of people got sick, 10,000 people, and a lot of people needed some type of rehabilitation. And actually this was the start when also physical therapy here in Morocco started, because there was physical therapists came here, doctors, nurses, but also 5 occupational therapists, and 3 of them were from Switzerland and 2 from Canada. And I had the pleasure, I think I said this last year, but I had the pleasure of meeting one of them. She's 90 years old, and she is still alive in Basel. I spent with her 5 days in her home last year, and she's a good cook. Anyway, and so she was actually one of the earliest. She was the first OT in Switzerland, but also she was the first OT that's practiced actually here in Morocco and helped a lot of people. And so, but the thing is, people went back and then OT went with them. So until 2016, where we got together with Handicap International, and Esther is here. So Esther, yeah. So if you, can you come? No? Come on, come on. All right. So was actually we invited Valerie, one of the workers with Handicap International, who is managing the OT projects here in Morocco. But unfortunately, she could not come. She want to share with us also the experience here. But in 2016, we got together with the Ministry of Health, the Occupational Therapy Association of Morocco, and Dr. Hajiwi is here. Yeah, Dr. Hajiwi is there. Mariam Fortasi, Dr. Fortasi, who talks before, and we come up with a curriculum, and we work together to create the program here in Morocco, and that is Handicap International now kind of supporting it financially, and the Occupational Therapy Association. The program started actually in 2017, but we created the National OT Association in 2016. In 2017, in December, we become fully accredited by the World Federation of Occupational Therapists. And this is a great honor that the program is fully accredited by the World Federation of Occupational Therapists. And the future of OT in Morocco are actually here. I would like to have all the students, the OT students from Morocco, to stand up. Can you stand up? So what you see now is the future of OT in Morocco. And so these students are the one who will kind of bring this profession to Morocco. And we are here to support you. We are here to help you to get to that level of when you can spread and teach people what OT is. A lot of challenges that my colleagues talks about are actually similar. Students have difficulties sometimes with finding field work. We did not have any OTs here to supervise them, so we were bringing some OTs from abroad. I was the honor also to teach them in last March, and I will be coming this March to teach them as well. We had here Inda, one of the speakers later, she came and taught as well the OT program in Morocco. And we are learning from different experiences, especially from our Arab colleagues, because we have a lot of similarities in the religion, culture, the language, and a lot of things that we can, instead of wasting time learning how to do, we are learning from them as well. And that was actually one of the main reasons of having this presentation. Our neighbors, Tunisia has also OT program, but it's not fully accredited. It's an associate member, and it started in 2004. And I think they have every semester, every year, they have a 25 student. In Algeria, they have also an OT program, but it's not accredited yet by WFOT. But Morocco is the only country in North Africa that has a fully accredited program in WFOT. All right. So I hope that you learned about what OT is, or the occupational therapy is. We have been, with the help of some students here, we have been spreading OT across the country, and also with the help, and also I will offer my gratitude and thank to some of the faculties and students from America who come with us every year to spread the knowledge about what OT is, and we help people as well in providing some treatments for them from Marrakesh, to from the south to the north. And we presented about autism, Alzheimer, disability, neurorehabilitation. So we did a lot of things that OT can do, and I think the sky is the limit, so we can do more in the future. I don't need you anymore. Murad. Unfortunately, Dr. Natasha Layton from Australia, who's a colleague of mine, she apologized she cannot come, but she sent us a recording of her presentation, and then we'll, after that, we'll do the keynote. سيفتي كلمة معنا للدراب باكس ليس اللينك ديالها تيشارجيتو ما نعرف صرت اسوي الدراب باكس هذا لا لاحظت هذا هو كنت هو عندي هنا سهل صح هو هذاك صافي
It's a pleasure to be here at the second annual conference of the Occupational Therapy Association of Morocco. My name's Natasha Layton. I'm a senior lecturer in occupational therapy at Swinburne University and the immediate past president of ARATA, the Australian Rehabilitation and Assistive Technology Association. I'll be talking about assistive technologies for participation in everyday occupations today. Greetings from Australia and from the Pacific. I'd like to acknowledge the role of the WHO and the GATE community, Global Access to Assistive Technology community, in bringing us together as occupational therapists and as assistive technologists. I'd also like to acknowledge my good friend Saeed Nafai and two very important communities. One is the occupational therapy community and another is the newly emerging Global Alliance of Assistive Technology Organisations, which Morocco and Africa may like to consider joining. My topic is assistive technology for participation in everyday occupations. And here you can see some of my colleagues who live with disabilities and are assistive technology users and have informed this presentation. They are Carl Thompson, Ricky Buchanan and Lynn Foreman. Carl, Ricky and Lynn are able to live full lives thanks to assistive technologies. AT is a key strategy to support body functions and structures and to enable activities and participations. Occupational therapists are experts at matching assistive products to people, occupations and environments. But this work can be challenging and it's influenced by many factors outside of the occupational therapist's control. Let me start by sharing my conclusions. To enable us to work effectively, we need to, 1, speak with a common language, and I'm going to suggest the WHO ICF is a good language for us to use. We need to engage in systemic and inclusive practice. We need to measure our outcomes, and we need to consider the relationship between practice, research, and policy. The World Federation of Occupational Therapy guides our scope of practice. Occupational therapists remediate body structures and functions. We modify activities. We facilitate participation. Occupational therapists turn environmental barriers into facilitators. We address and we strengthen personal and contextual factors. Sometimes we use occupational languages, particularly with each other, with terms such as occupational analysis. Sometimes we use medical language such as assessment, treatment, prescription. We may use the term patient instead of client, consumer or participant. I've spent many years listening to different professions trying to communicate, seeing different international communities trying to understand each other's practice and seeing governments trying to decide which interventions to fund. There was a strong case to be made to use international frameworks when we describe what we do as occupational therapists. Pictured here are the World Health Organization family of international classifications. The ICD classifies diseases, the ICHI classifies interventions, and the ICF classifies human functioning. Today. Here we can see occupational therapy interventions clearly aligned to key parts of the ICF. Chronic illness and spends about 23 hours a day in her bed. The ICF gives Ricky and I a way to describe her status and to identify supports and interventions. And you can see these listed here against the 4 categories: body structures and functions, environmental factors, activity and participation, and personal factors. The personal factors concept is very useful to capture strengths such as autonomy and resilience. And the reference on this slide is a journal article by Ricky and myself. The act of storytelling as a consumer is a protective and an emancipatory action that can build self-efficacy, and as an example, we've used here of an activity to strengthen these personal factors. We're going to focus on what the WHO terms environmental factors. The reason being, this is where assistive technologies fit. So environmental factors include natural and human-made changes to the environment, support relationships, attitudes, service systems and policies. And you can see at the top there I've highlighted products and technology, and that's what we term assistive technology. The International Standardization Organization, or the ISO, define assistive technology as any product including devices, equipment, instruments and software which is either specially designed and produced or generally available, whose primary purpose is to maintain or improve an individual's functioning and independence and thereby promote their well-being. The WHO Gate also identify assistive services, which are the development and application of organised knowledge, skills, procedures and policies relevant to the provision, use and assessment of assistive products. This includes training in the use of assistive technologies and other infrastructures to promote the effectiveness of assistive technology, and a reference for that is the Casnabis reference. So you can probably hear already there are products and devices, but then there are the soft technologies or the human skills or the therapeutic capacity to match those to the person, which is where the occupational therapist fits. Two assistive products are pictured here. Firstly, there is an app on an iPad which enables consumers to see and to co-design the position of handrails and other modifications to their homes. This was developed through Swinburne University in a collaboration between occupational therapists and designers, and it was to manage the high levels of dissatisfaction, abandonment and non-use of modifications and adaptations by consumers who felt they weren't taken on this journey. Secondly, on the right you can see a set of ingredients for hand function activities for children with cerebral palsy, and this is being deployed in the Pacific at the moment. And the point here is the activity of making Play-Doh is as important as the availability of Play-Doh used as putty for hand exercises. Both of these products illustrate the hidden soft technologies of occupational analysis, dialogue, collaboration and engagement. The second and third type of environmental factor identified by the WHO are natural, environment and human-made changes to environment, support and relationships. And the picture here comes from our colleagues at Motivation Australia working in Samoa. And here interventions must be adapted to the natural environment, and there are many design considerations to think about with human-made changes to the environment. Also, cultural attitudes to disability and family mean that supportive relationships may be key barriers or key facilitators to participation outcomes, and that means they are part of our scope of practice as occupational therapists. Services, systems and policies are also critically important environmental factors, and these pictures show some of the accommodations available there where there is a willingness in government and civil society to create enabling environments and to fund supportive technologies. This is not always the case, and there is a role for occupational therapists to advocate for adequate resourcing and for meeting our obligations under the Conventions on the Rights of People with Disability. Together, we can see some strategies that occupational therapists may engage in with Ricky. One strategy is reducing impairment. Surgery and medication are often used to reduce primary or frank impairments, and occupational therapists have roles in supporting recovery from these interventions. Compensation for impairment is another strategy. This might involve selecting activities suitable to being housebound and bedridden, using energy conservation principles, work rest routines. You can redesign activities using joint protection techniques or work simplification strategies. Introducing assistive technology per se, so mainstream and assistive products and services. Redesigning the environment, altering the manual handling, the reach range, looking at continuous path of travel through the house and looking at what's available within the visual field, or using personal support or assistance. Ricky has support workers, and as she says, they cooked, but I direct. I cook because I direct their cooking. So the ability of occupational therapists to construct these solutions from these intervention options is often tacit or understated, and it's very complex to get this right. There's also a role for systemic advocacy to meet the human right for inclusion and participation. Ricky accesses the world through her computer. Government funding will cover self-care supports like an accessible bathroom, shower, chair, adjustable bed and commode, but a much wider range of supports are needed for participation in online work and play. And in terms of our ICF environmental factors, we've deployed assistive technology, but we've also advocated for government and funding system change, demonstrating the cost effectiveness of keeping Ricky at home and able to manage her activities. We know there is unmet need for occupational therapy and for assistive technology, and I'm very conscious that many of the pictures I've shown you have been from high-income countries such as Australia, and they may look fairly different in terms of the practice that you're able to engage in as occupational therapists and the supports and resources we can deploy. We know there is substantial unmet need for occupational therapy and assistive technology across the globe. My PhD research, the Equity Inclusion Studies, demonstrated that people in Victoria, Australia, required on average 8 to 12 products, but usually just had one funded at a time, and might wait 18 months for much needed technologies, great cost to the healthcare sector while they're waiting. Our GATE colleagues are publishing a global report on assistive technology, which contains stories such as this here from Maurice Mbanza of the Congo, about the lack of both environments and technologies to support survival and to support participation. So here are a few ideas about what we can do. One strategy to address unmet need is to really clearly define impacts. So here Carl tells his story. He has what we've termed the assistive technology bundle. It's no good having the wheelchair without the rails, the ramps, the charging unit, the capacity to get this in and out of doors. So he's listed out his bundle, including the soft technology or therapeutic supports that he may require. And what we've done is looked at the activity and participation chapters of the ICF and been very specific about what one particular accommodation, and that specifically is his seat elevation on his power chair, to demonstrate the sort of outcomes you can get. So with this one feature in the power chair, you can see that self-care is enabled. We don't need to change the height of various work surfaces around the home. Might need support of one person rather than two for transfers, and make it much easier to use a hoist because we can adjust the height of the wheelchair for that transfer. Equal exchanges at different heights with individuals for interpersonal interactions and relationships. Able to communicate face-to-face, able to get up to the public bar at the pub, or be up at the lectern giving a lecture as Carl's pictured here. Access unfamiliar environments not built for purpose, and be able to see what's going on, his domestic life. Reach bank counters, shops counters, library checkouts and so on, and increase his reach range with a very limited hand function. So you can see that rather than just ticking off mobility, we're actually ticking off a huge range of outcomes with that feature, and being explicit about that is a way to identify what unmet need is. A further strategy is to make the economic case. So for Carl, for Ricky, for others, what can be done is to actually cost out what the assistive technology and related supports might cost in financial terms, but also look at what we can supplement or substitute. The first column there lists out direct support work and other direct costs that might be replaced by assistive technology. Column 2 suggests that downstream cost savings can occur. So if this is preventing expenditure in other areas such as health, and the third column identifies social return on investment from a holistic point of view. We can engage in outcome measurement. This might just involve collaborating with our consumers or patients in measuring function before and after our occupational therapy interventions in an N of 1 study. Or it might involve establishing a bigger study. Models such as the Impact 2 can really help work out what our interventions are, and we can use the Convention on the Rights of People with Disability to identify human rights and whether this right is or is not yet realised. In the reference list here, Val Watchorn, an occupational therapist, and myself have identified which assistive technology can enable human rights, and suggest how we might advocate for this. You can see here a list of the articles in the Convention that directly call up assistive technology, and with our consumers we can look at whether that right is realised or not yet realised. And finally, connecting with our communities of practice is a powerful strategy to ensure our practice informs research priorities, informs policy, and is able to be continuously improved. Our occupational therapy professional associations are essential for this, but of course many other professions and stakeholders are involved in assistive technology. For those of you interested in AT, there is an African community on assistive technology with about 100 practitioners from about 30 countries, and you're all welcomed free of charge to join its email listserv and to share information by emailing the link pictured here. Some of the largest assistive technologies include AAATE, ResNA, ResCo, ResGer, TRITS and Errata, and these formed the Global Alliance back in 2019. This alliance is keen to support new assistive technology associations to develop. Everyone can help develop AT in Morocco and add your voice to the African community on AT as one strategy, one way to do this. Thank you.
Thank you, Dr. Layton. Hello. Okay. It's an honor to have the president of the American Occupational Therapy Association to be our keynote. So Dr. Wendy Hildenbrand is the president of the American Occupational Therapy Association, and also she's a clinical assistant professor in the OT program at the University of Kansas, USA. She has earned a Bachelor of Science in Occupational Therapy, Master in Public Health, and also her PhD in Public Administration. As an occupational therapy with over 30 years, Dr. Hildenbrand practice experience include work in mental health setting, school-based practice, and community health context. Professional expertise include leadership, policy, advocacy, population, public health, and bridging policy and practice. Her research examines role conflicts in frontline occupational therapy professionals when implementing policies and maintaining professional values. So we are honored to have you, Dr. Wendy.
Oh, there was so much going on up here for just a minute. Hello, I guess I'm Dr. Wendy, which I love, so that's great. And I am the president of the American Occupational Therapy Association. That has just happened July 1st, so I'm very excited to be here. I find that wonderful to say you are honored. It is truly my honor to be here today with a room full of our future in Morocco, and a room full of just very interested occupational therapy colleagues and friends. And so thank you for this invitation to be here this morning. The title of my presentation today, Professional Sustainability, Occupational Therapy, Relevance, and Resilience, I believe has a message that is pretty universal. So I hope that it's received in that way and is one that you take home with you as a message of hope and as a message of optimism for where we're going as a profession. Where are my New England people? Go Chiefs. We have football in America. That would be American football, and I have to do that because there is a little football rivalry between to go walking down to the beach from our hotel in the short hour and a half. It was like, what would you do with an hour and a half if you were landlocked in the middle of the States and the beach is 5 minutes away? That's a no-brainer, isn't it? So anyway, my last slide today is that experience. I also bring you greetings from AOTA's Board of Directors. Those are the folks that are standing here with me. I don't do my job by myself, and it's important to recognize the people that are a part of the work that I am engaged in on the Board of Directors, but also on the behalf of so many people in our American Occupational Therapy Association. University of Kansas, always got to put a shout out for the hometown. I also just want to share with you that gratitude moment. It is indeed a privilege to be here, and I'm very thankful for the opportunity. Thank you, Saeed. And I am also very thankful to you for your time and attention here in the next 30 minutes. The only thing worse than being between a group of people like this and break is being between a group of people like this and lunch. So I'm well aware of that. I'll pay attention and I'll do my part here. You can check me later, okay? The title of this presentation, Professional Sustainability, I'm going to just say something shortly about that. I could have Moses come up here and talk about sustainability, and he would just put me in the ground because that is his thing. And I really appreciate his expertise and ongoing efforts about sustainability with the World Federation of Occupational Therapists. But I did include that in my title purposely because the remainder of my presentation, looking at relationships, resilience, and relevance, I think those things are so critical to the sustainability of our profession. Sustainability, when you think about it as a word, as an action, as an aspirational goal, is about us being careful stewards of our resources, about meeting the needs of the present without compromising the ability of future generations to meet their own needs. When I think about that, we can all think about it within a global context, an economic, environmental context, all those kinds of things, and that makes a lot of sense to us. But I also just want to put that out there as something we need to keep in mind for our profession. We do have limited resources sometimes. We do have decisions we need to make about how we commit our time, how we commit our energy, and how we really focus occupational therapy as a profession. And so I add that to that mix because that responsibility for sustainability is on us. And so I'm throwing that back out there at you because I'm not responsible for that alone either. I don't do much alone. Okay? I am going to just touch for a short minute. Professional sustainability is where I'm focusing there. Looking at occupational therapy as a profession, one piece of that. And then occupational therapy professionals also need support in that sustainability area. For those of us that have been in this career for many years plus, some would say we are sustaining. Some would say we're approaching retirement. I don't know, pick your word. But there's also a group of folks in this room that are very excited about getting started. And you're getting started and you're continuing your profession so that you're going to be all these people that you've seen up here today that are saying they've been at this for 20 years or 25 or 30 plus, and on, says Ann. So, but we're counting on you. But that means that you've got to take care of your career. You've got to take care of your professional trajectory in order to be sustainable within your career decisions. So that means being dynamic and flexible. That means that employability is a thing. You want to have a job. That means you need to make good skill matches. You need to match up with the things that matter to you and the things that align with our profession. And we also need to make sure that you know that it is okay. I wish I could find the woman who was talking about med students. Same applies to occupational therapy students as well, and the need to care for yourself in the midst of all of the wildness that goes on when you're in an academic program. As a profession, we're responsible for sustainability, for our profession, taking good care of it, educating our workforce, recognizing the growing pains and gains that come with an evolving profession and that are contextualized in many changing situations. The fit in many places. I've had some conversation with how challenging it might be to bring occupational therapy into a place where they don't understand what we have to offer. They're not seeing the fit. And so we have that responsibility and opportunity to make that very clear for people. That's going to help extend us and help us be sustainable. Passion that translates to the recognition of the distinct value of occupational therapy. It is indeed our responsibility to talk about occupational therapy, because you know what? There's not a lot of people out there talking for us. That is our responsibility, and we know it best. So we're going to give them the accurate picture. It's not going to be somebody else defining our profession for us. So that's a very important piece for us to take ownership of and see that as a privilege, as much as it can be a challenge at times. And then also, as you've heard in different times, we're only going to be as sustainable as a profession as we do legit occupational therapy. We do it in a way that's occupation-based, we do it in a way that's evidence-based, and we do it in a way that has the person, the family, the community at the center of our reasoning and how we implement our programs. Okay, so sustainable, we can do that? Yeah? Okay, all right. I know lunch is happening, so I'm going to make you talk and breathe, okay? All righty. Now I want to shift, though. That professional sustainability, that is the big thing, and obviously that's on my mind. But not because I'm concerned, not because I'm fearful about it, but because I'm excited about that. There is a generation coming behind us. There are multiple generations still in the mix. So we are learning from each other. We're doing with each other. And we will continue to move forward. But sustainability is something that, is an important part for us to kind of keep in the forefront of our mind. When I was at our national conference in April, that was my opportunity to do my inaugural presidential address. So I had a lot of room to screw up and, make things not quite right, and they were still being very kind as an audience at that time. I don't know if you guys are going to be so kind, but I guess we're going to find out. But I wanted to bring with me today, as a part of this conversation about our sustainable strength, or our professional strength and sustainability, I wanted to revisit what I called my 3 R's. The basics of what I think we really need to be doing if we are going to sustain as a profession. I say that knowing that, occupational therapy as such, we just celebrated our 100-year birthday, So we had a big party in Philadelphia. We had a good time. We acknowledged all of that. And yet, we continue to find all the places where we struggle, all the places where we can do better, all the places where we want to do more. And the conversations that we have 100 years later are not that different than the conversations that are happening 2 and 3 years in right here in Morocco, okay? So these things are basic, I think, just requirements for us if we're going to continue to stand strong as a profession. So I just share these with you, today. Relationships, resilience, and relevance are the 3 things that I'm going to talk about here shortly. I hope I understand the cursor problem, guys. Jeez. It's a thing, isn't it? There we go. Relationships. We're going to start there, okay? And I start with relationships every time because for me, relationships are very personal. Relationships matter a good deal to me. They are central to the way I live my life personally, the way I live my life professionally, and I hope in the way that I lead in this position as president. The other thing that I know is, I just want to say I do have some of my relationships here. My daughter and my sister are here, so that's been exciting to be able to share that. How fun is that? They've had an opportunity to see this community that we have, these relationships in this room. But it's been equally exciting over the last few days to be able to have conversations with so many of you who have talked about the importance of your relationships, whether it's with your families, your friends, whether it's with your professional colleagues, whether it's with the people that we serve with our occupational therapy community. So it's been a very exciting time, and it's encouraging to know I'm not the only one that values relationships, right? So when I talk about that, somebody's going to listen because they're going to want me to listen to their stories too. So that's a good thing. Is Yasmina here? I told you, didn't I? I was having a wonderful conversation with Yasmina just yesterday. She's from one of the schools that was left off the list this morning, right? You know, there you go. So want to make sure you got a shout out there too. And we talked yesterday about the importance of family and how critical that relationship is to just our overall just personal health and sustainability, but also to the relationships that we have, with our patients, with the people that we serve in communities. And so I asked her if it would be okay if I shared her picture today, as she told me the story about her grandmother and the relationship that they have here in Morocco, which was pretty exciting, I thought. And so I just wanted to thank you and say thank you for sharing your story and your pictures. I've had the same conversation. Hashem and I were talking about, families and what a big deal that is, how important that is in Jordan. And even not only just the family structures and community structures, even physical building structures, many things that keep people connected, but so critical to the work that we do and the understanding that we need to have. Relationships with professional colleagues. I don't know. Have you seen this guy running around here? He's hanging out all over the place taking pictures. I don't know what he's doing. But professional colleagues, equally important relationships, right? For the students in the room, I always tell my students at University of Kansas, it is an incredibly small occupational therapy community. When you start thinking about your colleagues and the people that surround you, the people that you work with, it is a very small world. That can be a very good thing. That can be a very not so good thing. So watch yourself. Somebody's listening. But it's also nice to know that you do have that community of colleagues, of professional support system, and people that you can call on. And so I just really encourage you to nurture that. Make those links, make those connections. Golly, 300 of your closest friends in here. What are you going to do with that, right? So I really, encourage you to think about that. These are friends I made in the last couple days. How exciting is that, right? And I bet I can call on them, and I will. So just take note. That was a warning. And then also professional relationships with the people that we serve. What a gift. Is that not a gift to be invited into somebody's life, to spend a little bit of time with them, to understand the things that are meaningful? We can start right there this morning. The things that are meaningful, the things that are priorities, and where they want us to help them focus their energy, their time, and their expertise, okay, in support of their best life. So I just encourage you, this was 2 days ago. This is why I didn't send my presentation not by the due date. I said, can't do that. That's got to come with me. So anyway, this was just a couple of days ago at the community center in Casablanca. I did not know this woman when I walked in the door, but I got the best hug when I left. And the same right here with my daughter Jordan, working with her son. So I had that opportunity to watch that relationship as well. These are the things that are important. These are the things that help us sustain those relationships with people we serve, and these are the things that help us get connected to our communities and help us be the occupational therapy profession that we want to be. Just a side note here, and I always follow up that relationships part with just a reminder that civility, as much as respect, understanding, communication, compassion, all those things are critical to the relationships that you want to have, that are going to be productive, that that are going to be positive, that are going to help people stay on the same page and move forward. Unfortunately, there's an awful lot of things that are happening these days that are not civil. I don't have a lot of time in my personal life, or in my professional life for that matter, for incivility. That doesn't rest well with me. And so I just put this up here as a reminder that civility will go a long way in helping support those relationships that are so critical to us as a profession. Okay. Resilience is something else. So I talked about relationships, right? Resilience would be my second R as a basic, right? Relationships, resilience, relevance. We're getting there. Resilience is a big thing. That's about, recognizing the tough stuff. That's about dealing with adversity. That's about acknowledging when you have to persist, even when you thought you got there. That's resilience. And as a profession, resilience is a big thing. I mean, I'm sure, Saeed didn't wake up one day and say, this is going to be easy here. No, it's taken time, it's taken commitment, and it continues to do so. No different anywhere else. The pictures that I share up here, if you've seen, the history of OT textbooks, those folks over there on the right might look familiar. Those are founding fathers and mothers. See, we'll have to put you in there for the next go-round. The people that started, though, 100 years ago, somebody told them no. Somebody probably told them that's a crazy idea. Somebody probably even said, what are you thinking? But what they were thinking was, we need a profession like occupational therapy that's grounded in principles about meaningful daily life. So they said, okay, we're going to do it anyway. So there's a lot of times where we're going to have to say, okay, and do it anyway. All right? Do it anyway. It's not always an easy road, but it's a good road. So you got to keep putting that one foot in front of the other. Okay? These people over here, this is my family. So I just share them with you. Again, why? Relationships are important to me. That's a pretty big deal for me. And the people in that picture, kind of like some of you in here, if I asked you, are you resilient? Do you have stories? Have you been able to manage adversity? I bet you'd say yes if I asked, but I bet if I'm just looking at you, I don't know your story, right? I don't know what's there. I don't know what tough stuff you've had to do. Yet I know here you sit strong, right? And when I look at that picture, when I think about them being home when I get back, that's strong for me, okay? And the stories in that picture have resilience written all over them, okay? So I just share that with you. This is resilience. And I share this one. The picture at the top was one that I found. These were women that were celebrated as leaders of courage back in 2017 from this region, which I thought was pretty cool. And I was like, all the many different agencies, initiatives, things like that are represented by women in this region in this picture. People that have had to say, I've got that resilience thing, and it's working, right? And I'm going to do well for others. I'm going to do good. This little girl, we met her 3 days ago. And that's a beautiful face of resilience right there. Continuing to want to know, how does she do her next day with a little more ease, a little stronger, satisfy goals that she might have. But the backstory to this little girl too was sitting there. Where's Kelly? Where are you at, Kelly? Hey, there you are. Sitting there watching Kelly and students working with this sweet little girl. And I'm sitting there also watching her mom. And her mom is standing right behind, what was going on. Hashem standing there next to her, having a conversation. And what I'm seeing is the tears just start to come, okay? And they're not pity tears. They're not shame tears. They're I love my daughter tears. And how can we do better? What can I do? Okay, what are the needs that she has? This is the place where it's hard, okay? So I share this with you because resilience has a whole lot of faces. And it's that resilience, that opportunity for us to support people where they are and help them find whatever place they want to get to. That's occupational therapy. We have challenges. I'm not going to spend a lot of time on this. I think it's, you all have your own regional, national, challenges that, for the good or bad of it, sound so incredibly familiar. And it means we have a lot of shared work that we can do. It means we have a lot of ongoing work we need to address. But we do have issues with healthcare costs. I mean, that's the thing, whether it's about, are people doing private pay, or whether it's about, are we in systems that the reimbursement models are favoring, this sector versus that sector, whatever is the thing. I mean, it becomes challenging. And we know that we're needing to get paid for services. We know people need our services, and sometimes payment is short. Okay? So I just, that's a real issue. And that makes it challenging for us sometimes as a profession. Demographics are changing in this. And if we talk about Morocco specifically, I believe there's a shift in some demographics. There's a shift in this region in some places. It's a very youthful part of the world, right? There's a lot of young minds, young people. And with that comes, maybe some different ways of thinking, different ways of doing, pushing some systems, asking hard questions. That's a demographic change that's going to make everybody think hard about how we work together. That's not a bad conversation to have, because that doesn't mean that one's good and one's bad, or one's right or one's wrong. It just means we've got an awful lot to pull on together, and pulling together will be the key on so much of that. Education, you guys have programs here. That's exciting. You've got accredited programs here. You've got developing programs in need of support to have that recognition. That is exciting, but yet very young. Very young. So we've got this wealth of opportunity out here. Where can we go? Where can occupational therapy do their thing? But we don't have enough people in the hopper yet. We don't have enough graduates yet in some places here. So we continue to develop that pool. We need more faculty, though, to help develop that pool. So these are some of the challenges, but that doesn't mean we quit. That's where that resilience part comes in, right? So for all these wonderful people that were sitting up here at this table, there's a whole lot of resilience going back home with them. And they weren't short coming in, I'll just tell you that, right? So these are the things that we need to recognize are moving us forward, okay? We have challenges, but we have opportunities in those challenges. And we also have the responsibility to be relevant if we're going to be recognized and have the opportunity to see some things through, okay? Professional resilience, I just want to put this up here kind of to follow up even a bit, wonderfully, but unknowingly on the woman that spoke about med students. Professional resilience, it challenges you. For all those times where you're out there having a great day, there's a minute where it gets tough. And there might be 2 in a day, so don't be discouraged by that. But you have that opportunity, and you do have it within you to say, I'm good. I've got this, okay? Even with everything going on, I can achieve balance amid occupational stressors and life challenges while fostering professional values and career sustainability. We need every one of us in this profession for the long haul, whether it's about staying where you're at, retooling, redefining, going where you want, but we need you. And so do what you need to do to take care of you. Huh? Okay, gotcha. Thank you. Okay. You can come to these because I will load this with Elizabeth, and she'll take care of things I know for the program. Things that you need to do for caring for you, taking care of your own physical and psychological self-care will be critical. You've got to do that. You've got to draw on whatever is your foundation of inner strength, Everyone in this room has their own belief system that's very personal to them and guides how they do their day, guides that place when things get hard and they need that extra strength, okay? You've got to identify that because it's yours. It's yours, and that's what will get you to the next day. Another building block would be personal and professional value. Knowing what that is, not only what you value, but what your values are. Because when you're clear about that, when things get tough, you're going to know where you stand, and you're going to know what kind of risk you're willing to take in order to make sure other people know that as well. And you'll feel good about it. Professional goals and aspirations. What do you want to do? What's your big deal? You've got to have something. Unlike, popular opinion, this was really not my aspiration to be standing up here as AOTA president, but wow, what a gift and an opportunity for me. I would never be in front of this room in this capacity without having said, okay, I'll give that a go, and I hope I can make a difference. So what do you want to do? What's your goal? What's your aspiration? Because that will help you plan. That will help you do. That will help you stay engaged. And belief in self-advocacy, I go back to that thing where nobody's selling OT but occupational therapy folks, okay? We do have friends and colleagues. We've been gifted with the presence of many people here from universities, from our association partners, from some of our government officials. That's an army we need. They're the people that are walking this with us. But we need to be able to advocate for ourselves. No offense to physical therapy colleagues, but we're not doing infomercials for them, right? We need to sell us. We need to sell us. And when something's being said that is not representative of occupational therapy, we need to address that. That's our job. If you live in Kansas, you know what this is. If you don't, it's okay. It will go away. But The Wizard of Oz is a classic movie that represents things close to me. But these are characters in that movie that are very resilient. They had a long way to go to get to find the wizard with all the answers. But the thing that they were all looking for was relevance, something they felt was missing that made them relevant, okay? So we'll take that, though, to a different place that we can all relate to, which is what is relevance. And relevance is the place in the middle there that really matters not only to us, what we think is important, but also matters to other people. Those other people being agencies, those other people being other discipline partners or, professional partners, okay? People that share the same passion as we do. How fun is it when you sit next to somebody and all of a sudden you're talking the same language? You've got the same passion. You've got the same fire about something, even though you just met. It's like, what? Where have you been all my life? Right? I mean, that's exciting. That's where that place in the middle gets really fun because it becomes relevant. Your conversation's relevant. The things that you do become relevant. And it's important to kind of identify that zone. Authenticity, mastery, empathy, and action would be 4 things that I would connect to relevance, how we establish that relevance. Authenticity. We have got to be authentic occupational therapy professionals. We are not somebody else. We're occupational therapists that know what daily life is about for people. And we're occupational therapists, or occupational therapy assistants, by the way, that are able to connect with people and find out for them what's authentic in their life. Because, again, when we can find that place in the middle where we know what matters to them and we know how we connect, that's huge. And that's the place where we establish goals and treatment plans and discharge and all those things that support them. So authenticity is a big thing, knowing the real thing. Mastery, we have got to be good. We've got to be good at what we do. We can't be second, okay? We're the occupational therapy professionals, all right? They're in the States and I'm sure it's, similar here, there are other groups of people that think that they are doing occupational therapy, and they're not. Make no mistake about that, okay? They might be taking some pieces of what we have, and they might be doing that really well. That's all, that's good, but that's where they would even be better in partnership with occupational therapy, the overall principles and philosophy that we hold as a profession. So those are partner opportunities that we have, and we'll be able to demonstrate why we're the folks with that expertise. If we're good at what we do, if we articulate what we do, and if we do better, not imitate other folks, be our best occupational therapy. Empathy's come up a couple times today. That also helps us be relevant. If we can't connect with somebody to know where they want to go, to understand that this might be a hard spot for them, we're going to be doing a lot of things that don't matter to them. If they don't matter to them, we are not relevant to them as care providers, okay? So we definitely need to be drawing on that empathy kind of gene. And then none of this is going to come together and matter if we don't do something about it, people. Do something. We can talk to one another all day. We can talk about it a lot. And we do. But if we don't put into action this occupational therapy gift that we have, nobody's going to benefit from that. No matter how authentic we are, no matter how much mastery we achieve, or how much empathy we cultivate, relevance is impossible to attain without action. People will not know what we have to offer. People will not see how we demonstrate occupational therapy in the right places with the people that need it. So it's going to be important for us to get there. When we are relevant, we matter. The more relevant we are, the more choices we have about what we do, where we do it, and how much our services are valued. I mean, these are the things we're trying to get to, right? We want to have choices about where we work. There's things that get in the way. Systems get in the way. People get in the way. A point in time serves as a barrier. I mean, that's okay. That just means maybe it's not now, but it means it's coming. Because we persist, right? We keep doing. So it will happen. The value piece is huge. And again, that value is much connected with relevance. AOTA, they had a big campaign. It still is a relevant campaign, if I can just use that word again. Looking at distinct value. What is our distinct value? And the very first part of that phrase talks about occupational therapy's distinct value is to improve health and quality of life through facilitating participation and engagement in occupations, the meaningful, necessary, and familiar activities of everyday life. I mean, that's a distinct contribution we make. And we add to that, we bring additional value when we are client-centered, when we achieve positive outcomes, and when we add to the cost efficiency equation in these places, okay? So we need to make sure that we are recognizing the value and demonstrating that value to folks. We have opportunities. We have uncertainty. Okay, if I did this a year from now, I'd still have this slide because every turn there's opportunity and uncertainty. That is not a bad thing. It's also important to remember if I was here a year from now, I would still be telling you that we are in this together, okay? It is not about me. I say this at home all the time. It's not Wendy, the occupational therapy president. It's me, occupational therapy AOTA member, who wants to be working in partnership with my colleagues, with my clients. We are in this together. It's not a one-man, one-woman show. We have to be able to continue to focus on the we rather than the me. Here in Morocco, you've got things happening. Morocco and occupational therapy is a thing. You have a program. You've got interested people thinking about how to expand that. And you have opportunities here. You've got wonderful partners that recognize the value of occupational therapy, okay? There's a lot of places that wish they had that, and they don't, okay? So it's happening here in Morocco. That's a good thing. That's progress. That's movement toward continuing to expand that panel up here, the information that comes forward, the successes that they're able to share, right? It also means expanding opportunities for people in this room. You guys have issues, just like everybody else. There's no doubt. Health systems, human resources, practice environments, the challenges of just being an occupational therapy professional, it's real. But that's not the thing that gets in your way. So it's just something you acknowledge and go forward. I did come across something kind of interesting to me when I was wanting to know more about Morocco and health systems. And it was a health organization looking at positive practice environments for healthcare professionals. They provided a option here in Morocco. You guys are new to the game. There's going to be a lot of those opportunities and little bumps. There's going to be big successes and progress. But you might need to think about these kinds of things. Training capacity, you know, how do you recognize your professional group? You know, structural reform. Reform's not a bad word if it's done with the right reasons and gets you to places that are useful. Leadership, work terms and conditions, legislative and regulatory frameworks. And, you know, it's a part of everybody's life. So how do you work within some of those systems or address that? And international partnerships, and I said it before, I'll say it again. To be This would probably be my bigger challenge, though. Maybe I just dare you a little bit. Can I dare you just a little bit? I dare you to be hopeful. I dare you to remain optimistic. Even when it gets a little challenging, even when you're like, wow, is somebody still with me on this? They are. Look around, have the conversation, reach out. You know, reach within, do whatever it is that you need to do to maintain that hope and optimism for the future. Okay? This picture is from your beach. I said I took that hour and a half yesterday, and I walked to the beach. You know, not a lot of shells over there, I'm just saying, but there's a lot of great sea glass that was awfully pretty to see. And there were wonderful rocks. And the rocks that I found were heart-shaped. And so I just wanted to share with you a big thank you from the bottom of my heart. And I really appreciate your time and everything that's going on here in Morocco. Thank you so much.
Thank you.
Okay.
Unfortunately, Dr. Zuhair Lehna called me a few days ago. There is some urgent matter that he has to take care of in France, where he has also a medical practice. So he couldn't come with us, but he sent us a small video to express his gratitude about this award. 27 هذيك راه فوق منا محمد who's missing oh Dr. Wendy شوف الليست So we're gonna have a 1-minute video, so it tells you about what Dr. Lehna does, and it's an honor to also be partner with him. And so we do a lot, kind of some work together, and can try to help societies here in Morocco. هذا هو الفيديو نتفرج نكبره Okay. يكمل تحت راهو تحت ها ها طلع شويه صح ماشي مشكل غير الصوت انا نقول لك هيدا اطلق بلاي انا نطلق واخا شايف Okay, guys, please watch this amazing video. It's very short, but it just shows the work that Dr. Lehna does.
Les gens qui n'ont pas d'argent sont humiliés et je lutte contre ça en donnant des soins. كل شيء ديالك. ولكن حيدوا هذا الشيء قدينا كل شيء بالحرام. نعم. La santé reproductive au Maroc va mal, avec des hôpitaux qui sont surbookés. On a donc des patientes qui sont très mal suivies et surtout accouchent dans de très mauvaises conditions. Celles qui ne meurent pas gardent des séquelles. Qu'est-ce qu'on veut recueillir après ça? Soit les patients, ils ont des moyens, donc ils vont donc prendre un avion, voir des gens qui savent faire, soit ils vont rester avec leurs maux. Et comme ils sont très pauvres, ils restent avec le mal, avec la souffrance. Des difficultés à obtenir les urines pour les femmes les plus âgées, des fois des selles. Et quand elles vont consulter, par incompétence ou inconscience ou les deux, on les laisse comme ça. C'est ahurissant de traiter nos aînés, nos mères, comme ça. Donc je les opère, 1h30 à 2 heures, elles peuvent sortir le lendemain ou le surlendemain. C'est finalement d'une facilité déconcertante. Il suffit juste de vouloir pour le faire.
Une fois dehors, il a besoin de respirer. Quand il ne crie pas, donc il faut qu'on l'aide. La première façon de l'aider, c'est stimuler. Comme ça, mais si comme ça, c'est pas comme ça qu'on fait.
هذاك لو كونتاكت قليل اللي تيحس به malheureusement de nos jours et c'est ce que docteur Lana veut inculquer en nous بغى يرجعنا لي فالور de la médecine القدام انك تتحس بالو patient.
Je reste toujours optimiste pour l'humain, pour l'humanité. Je suis croyant et le croyant est sommé de planter les grains d'un arbre, même s'il doit mourir demain. Donc je plante. Et peut-être ceux qui vont venir derrière moi réussiront beaucoup mieux. C'est ce que j'espère d'ailleurs. Les gens qui n'ont pas d'argent sont humiliés et je lutte contre ça.
So, as he said, unfortunately, Dr. Hina couldn't come with us, couldn't be with us. So he sent us a very short video, 1 minute, about this award.
Ça fait même plein.
Ouais.
Assalamu alaikum wa rahmatullah. Hello everybody. I will thank you for this word from Occupational Therapy Association of Morocco and New England University in Morocco. Thanks for Dr. Said Nafi and Professor Brahmi for their work and for their interest for my work. I work about 20 years now to teaching gynecologists and midwives, and even in Morocco, Africa, and Middle. As you know, in the war situation, women are in the bad condition of treatment and health care. For me, it's this prevention is to protect, as you mentioned, their mind and their body for the women and newborns. So thank you and good luck for this Congress.
So just so if you don't know, Miriam was one of the presenters last year, and she's also a delegate to from Morocco to the WFOT, and she will be helping us presenting the awards. We'll start with Dr. Lehlo, who will be receiving the the Excellence Leadership Award for his work.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المخلوقين. أود أن أقول أن هذا التكريم يعني ما كنت أنتظره قبل أن يكلمني أخي وصديقي سعيد. تكريم لا أظن أنني أستحقه، ولكن أهديه لكل من يعمل في سبيل الناس اللي هما في حالة إعاقة، الناس اللي هما في حالة بريكاريتي، الناس اللي هما في حالة اللي تتوخى المساعدة. فأهديه لكل المغاربة اللي تيشتغلوا وتيوهبوا حياتهم للآخرين، الناس اللي هما لاحقين لهذا. شيء ثاني، أود أن أشكر المنظمين على الحكمة في التنظيم، على المواضيع اللي طرقوا لها، وعلى يعني لا كاليتي ديال الناس اللي هما دخلوا في هذا اللقاء اللي هو لقاء دولي. واخيرا اتمنى مقام سعيد للاجانب في المغرب اللي هي بلدهم الثاني. شكرا جزيلا.
So just so you know, Dr. Lehlo is a big supporter of occupational therapy and also lead a lot of associations, as you look here, that helps people with disability and people who are underserved as well. So we are so honored to have you. The next person is Dr. Wendy Heldenbrand, and we thank her for her promoting OT with us here in Morocco. Okay, and next one will be, so Ayub Shfigi, who is, we are honored to have him here, and he's well deserving of this award, the Student Inspirational Award. And this is a person, be careful the table. Okay, this is a student who is blind, but that did not stop him for pursuing his interests. And he's studying to become a physical therapist after finishing his law degree, of course. He does speak English.
1, 2. Hi, everyone. So I'm glad to be here with you. Thanks to Saeed and his team, Elizabeth also. So, what I say? My feet is getting cold. So, I did what I did. It's not a crime, of course. Of the support of my lovely dad and mom, even if they are literate, they don't know how to read or write, and they support me as a blind and visually disabled to study. And my dad and mom, Mubarak Shfigi and Minan Najm. Thank you.
And next one, who is also was big inspiration to me as well, Ikram, who she sees herself as anybody else, despite her not having hands, but she can do everything, including opening a little bottles. Like, I don't even know how she does this, but.
Assalamu alaikum. I'm so happy to be here with you. Thank you so much. And thank you for Dr. Saeed. Thank you for everyone. I want to say one thing. We are not handicapped. We are differently able. That's all. Thank you.
So Ikram, she went to South Africa, went to Qatar. She does a lot of work also promoting women's rights and people with disability. But beside all of this, she's a student and she also an entrepreneur. And she has like in a stall there, and it's about products for oil, argan oil. How many people here loves oil, argan oil? All right, good. So I want the table to be empty by the end of the lunch. Okay. So find your pocket and bring your money to her. All right. So the next one, I know I did not put in the program because they are so kind of do not want to be in the spot, but they have helped us so much. And first, I cannot be where I am right now. يعني ما أقدرش أكون أنا فين أنا من غير الزوجة ديالي اللي ساعدتني بزاف. My wife. And so my wife has been my rock, and she has been helping me so much. We have been coming to Morocco doing this since 2003. And where we were talking about people that they have autism, and nobody know what even autism is, but we recognized then what autism was. So she's a big supporter of OT in Morocco as well. You want to say something? Yes, please.
This is just a dream come true for us. That you're all here with us and that we're building Moroccan OT from Morocco, in Morocco, with Moroccans, by the Moroccans. That's the mission here. So thank you for being part of it.
And next we will be Morad bin Kiran. Where is he? Morad. Hi. That's why I said I know Morad cannot hold still. I think Morad and I, we have undiagnosed ADHD. You and I, we have ADHD. And so Morad.
Assalamu alaikum. I have no word to say, but only I hope that you spent good time today and yesterday with the pre-conference. We are here to support you and to support Saeed and his family. I'm not saying his team and crew. It's a family, yeah. And I wish you the best and so long for next year, inshallah.
Last but not least, my partner in crime, Professor Brahimi, who has been an amazing supporter for what we do, and we are so honored to have his support. That a lot of things that he has been supporting me, it's very valuable. So we thank him as well.
They like quacks like those? Get these too? All right. So I'm so glad that he put in a better picture of me here so I can hang it. Thank you very much. It's been a pleasure. It's been it's been quite a ride, doing this. Of course, I don't know how I got involved with people in position of disability, but I remember way back when I was 12 years old, and I saw a kid walking on crutches, and I don't know, something happened there that changed me. And I decided that, years went by, and I did find my calling, when I met Saeed. I happened to teach in a town where he lives. So we met, and it's been a tremendous ride. And, we're not saying that we help people, but you guys have no idea the amount of satisfaction that we get from all the toiling that we do here in Morocco. So thank you, I should say, to everyone that we've helped, and thank you to everyone that has given us the opportunity to be of service to them. The Prophet ﷺ said, the best of you are those who are of service to others. And we hope to achieve that status of being the best of us. Thank you.
And just also, one of the biggest supporters of what we do in Morocco is actually my high school classmates, students, who are here from the high school Ibn Battuta. And they are a group here, and we are so honored to have them here. And they come, while I'm in America, for example, the World OT Day, we, with the OT students, they met together and they helped people with disability during that day as a celebration for the World OT Day. So we are so thank you. شكرا كثير لمجموعة قدماء ثانوي بن بطوطة. استنى بن بطوطة وقفوا. So we'll gonna have lunch, and thank you, but let's respect the time so we can finish early. Thank you guys. We're gonna نتغداو دابا.
the stigma that is associated with dementia, at least in the United States and I suspect worldwide. So this is my opening plea along with my thank yous. I also want to give a shout out and a thank you to my newest Moroccan colleague, Dr. Hajar. She is a student doctor and she is responsible for converting what I say into French. And so for those of you who are hearing this in French, we have her to thank. And I was so glad to make her acquaintance in Marrakesh recently, where she showed us around and helped us get acquainted with Morocco. So my gratitude to you as well, Dr. Hajar. Here's what I hope you get out of it. This being an educational conference, got to have some objectives. But mostly what I want you to get from this is some language that you can use, particularly the students, in helping healthcare professionals who don't get it about OT, what it is you do, why occupational therapy is so essential for us to be able to provide high-quality dementia care. Like many other speakers who have addressed you, language is really important. I'm a physician, but I don't use a lot of the language of the medical model, except with respect to my own title as doctor, if that's how people come to see me. And in those circumstances, I also use the language of patient. But as you'll see very quickly, the word that is most useful to us is person. And so you will see, and I really ask you to make this a habit, that using person-first language is the way for us to bring our lenses together, to bring our professions together. So I never talk about a schizophrenic, a demented person, a behavior resident, though I know you'll hear these terms in clinical setting. Always I use the term a person with dementia, a person with schizophrenia, a person with whatever it is that brings them to see me. And I would encourage you to use person-first language as well, if you don't already. Many OTs do. Now, I observed everybody else having trouble, and I was determined to figure this out. The other thing about language is that I do come from a field of practice that has tended historically to always focus on the individual. And even in this day of person-centered care, it's been a very individualized focus. But from OTs and actually from my own experience, I've also learned how important it is to talk about relationship-centered care. And particularly in the area of dementia, we're talking about care partners who may be an adult child, it may be a spouse, it may be an older parent, but there will be others always involved in the relationship and in the dynamic of providing adequate support, rehabilitation, and care to people living with dementia. This term person-centered, which has just kind of become a bit of a buzz phrase in the US, always carries some of these notions. And the ones that I think are most important and that I would ask for your help in teaching other health professionals is this notion that we focus on the person, not the disease, on the strengths rather than the deficits, that we shift the authority about the plan to the individual and his or her family, the context that matters, but that also acknowledges that the care partners have their stresses as well, and that in attending to the needs of people with dementia, we also have to attend to the needs of their partners. The other new language that I'm starting to use, again, to invite you to think about it, is the notion that care is not just centered on the person, but actually is directed by the person. And that's what we mean by really engaging in care partnerships. It's not that I make you the center of what my good advice is, it's that we co-create meaningful plans for intervention. And that's what it's all about in dementia. Now, here's our challenge. People don't like to talk about dementia. People don't like to talk about Alzheimer's disease. And one of the reasons that they don't is that the Alzheimer's Association has done a terrific job of bringing to awareness the disease of Alzheimer's, but doing so with a kind of tragedy narrative. And so mostly when people think about Alzheimer's disease, they think about way down the path, rather than people at the beginning of a journey who are going to be living for a long time, possibly with dementia. So here's what the meaning of this slide is. Is D the new C? When I was in medical school, almost 40 years ago, we did not use the word cancer. So my instructors said, don't ever tell a person they have cancer. You will remove all hope. And honest, true story, students may not believe this. When I was a medical student, if a woman had a cancer in her reproductive organs, cancer of the uterus, we did not tell her. If she had breast cancer, we did not tell her. We told her husband or a parent. Can you even believe that? You talk about loss of autonomy. It's extraordinary. We've come a long way. We now talk about cancer, but now we don't talk about the D word, the dementia word, and we have to help people get more comfortable. Or is dementia not the problem, but just Alzheimer's disease? I've had a patient actually say to me, Doc, I can deal with it if I have dementia. Please just tell me it's not Alzheimer's disease. But of course, Alzheimer's disease is dementia, and it is the most common kind of dementia. But it is something that people are just so frightened of that neither they nor we want to think much or talk much about it. But I'd like you to think about silence for a moment and the not talking about something before we jump in and get everybody talking about dementia. And I'd like you to think for just 5 seconds. When I say the word silence, what comes to mind for you? What messages? What does silence mean to you? As an example, I was taught as a very young child that if I couldn't say something nice about somebody, say nothing at all. This is a common thing that mothers teach their children. If you can't say something nice, don't say anything. So I was quiet a lot of the time. And so I learned to be silent. But silence also has some positive aspects, and I'll just ask you to think for a moment. And those of you who are watching this on YouTube, jot down on a piece of paper, just 5 seconds, because we don't want dead air time. And then I will tell you some things that others have talked about with respect to silence. If you had your own reflective 5 seconds, here are some things that are associated with silence. People don't speak because of stigma. People don't speak because of fear. People don't speak also, though, because they need some time to process. For some people, not speaking is about peacefulness. It is about reflection. It provides a certain sense of security. And so initially, when the campaign in the United States was sounds of silence and the stigma, break the silence, and we were trying to encourage people to not feel the stigma, I think we lost for a moment the notion that actually it's okay to be quiet for a bit. Be quiet for as long as you need to be quiet. And the message for us as practitioners is to convey to our patients, to the people we serve, to people living with dementia and their care partners, we are open to hearing about it, but they can talk to us in their own time, tell their story when they're ready. We have to create the conditions of openness so they know we can talk about it, but we don't have to force anyone out of their silence if that's where they are. That's an important takeaway. The other takeaway has to do with the evolution in the field. And that is that when I first started practicing, and I've always been interested in older people, and so I've always been interested in dementia and diseases of the mind. And when I was ever asked to speak, I was always asked to speak about dementia from the outside in. What are the symptoms? What causes it? The disease model, the medical model. And then we began to see the limitations of that.
And we started talking about a person with dementia. And we have moved in the last decade, at least in the States, to really focusing on person-centered dementia care. But we have still left dementia in the equation. So we've moved from a person with dementia to a person with dementia. And now, as we reimagine it, the next wave for us is to just talk about the person. Because from the individual living with dementia's perspective, who they are and what they can still do is of much greater interest to them than what they can't do or what they have. And people who have the lived experience of living with dementia know that when people find out they have been diagnosed with dementia, perhaps due to Alzheimer's disease, people look at them differently. They talk with them differently. They treat them differently, and they don't engage with them in the same way socially. And that is where you can be so helpful in helping people understand that social engagement is one of the most important occupations that we all have. So from the person's perspective, who they are and what they can do is really all that matters. And so we talk about reimagining dementia in a new way. We talk about not interventions, not treatment, but instead, what's needed to maintain personhood in the care and service of people who have dementia due to Alzheimer's disease or anything else. And this little flower is taken from the work of Thomas Kitwood, who, if you're not familiar with him, I strongly urge you to look at his book, Dementia Reconsidered, written in 1997. It hasn't gotten better than that, in my opinion, in terms of really grappling with and understanding that we're talking about maintaining personhood, not treating a disease, not even intervening with a person with a disease, but we're doing what it takes to maintain personhood. If you can think of a better health profession, an allied health profession, to join me in this than occupational therapy, I'd like to know what it is. Because to me, this is what you guys do. It's what you've known all along, but we're just learning it, so you gotta help us. One of the ways that I try to teach medical students now, and that I try to teach my colleagues, is to turn that staging paradigm that we use. Patients and their families are often asking me, what is the stage? What is the stage? And what they want is this. They want to know what the person can't do. This is what you will see in most textbooks. I want to rewrite them, because what's of greater interest to the person is what they can still do. I'll tell you a little quick personal story if I have time. I do. A quick personal story about this can do, can't do dynamic. My father-in-law died about 3 years ago from Alzheimer's disease, and prior to his death, my partner and I would visit him at his home in Washington State, which is like on the other side of the country. This meant that I saw him about once a year or maybe once every 2 years. Not very often. On this particular occasion, I was visiting him, and Skype had just become available, okay? And his son lives back in Chicago, and I said, Joe, do you know that we could talk to Ted on TV? He said, no. I said, no, we could. Let me show you how to use this new thing called Skype. We set it up on the computer. His wife came in and said, why are you teaching him that? He'll never remember. He said to her, look, Ted's on TV. And I said, because for that minute he sees Ted on TV. And she said, he can't remember. He won't be able to do it. I said, that's where you come in. In her frustration, she just left the room. That 1 minute conversation made him, in fact, forget all about Ted. He turned his chair around, looked back at the computer, and he said, hey, look, there's Ted on TV. I said, no, isn't it great? When we left that day for the visit, as I was walking out, he looked at me and said, I have no idea who you are, but I always learn something when you come. Okay? Now that's why we do this work. Okay? And he didn't know who I was, and I don't come very often, but in that moment, he knew something positive had happened, and it had to do with his learning something new. Because in his prime, he had been a cardiothoracic surgeon. Quite accomplished, quite bright, always learning. And now, from his perspective, still learning, even if never remembering. That's what I want you to remember about what people can do, being where we put our focus, and worrying less about what they can't. Now, I will say that from the standpoint of talking to your medical colleagues, and from the standpoint of getting money to fund your research, you got to use the medical model, okay? You got to use it to talk to funders. But when you talk to people, talk about it the way we talk about it, okay? You get the difference? That the language of successful OT funding is about what you can do to reduce caregiver burden, stop behavior problems, and reduce use of the medical care system, because it's about saving money, getting better care, and reducing the burden on caregivers. There's nothing wrong with that. I'm not critical of it. It's great that OT, as a member of the team, helps achieve what are traditional medical model goals. That's great. You can help us do it. My message to you is simply that it's not enough. I think what this requires is simply patience, which I seem to be a little short on. So, reimagining dementia, from my point of view, means using this lens of recovery. The lens of recovery Dr. Ann talked about yesterday, and she acknowledged or observed that we all use it a little differently. So I'll tell you that when I use the language of recovery, and I borrow this from the field of mental health, is simply a way of living to make the most out of life. It doesn't mean you get cured for something. It doesn't mean that you get over something. It means that you make the adaptations that you need to make to get on with your life and to have a high-quality life and to live it with purpose and meaning. That's how I'm using the term recovery. And when you ask people who are in recovery, people with serious mental health problems, they will tell you that what it means to them is the ability to have hope, to trust their thoughts again, to feel alive and alert in their environment. And again, that's where you come in, is assisting in that environment for people with dementia. And they say, in the studies that have been done about people in recovery, what would you like for health professionals to understand? They say, I'd like them to believe in me, believe in my goals, believe in my perspective, believe in my point of view. And to the extent that you can be helpful, be clear about what it is I need to learn about. It's called the Dementia Action Alliance. And her plea is the same as the one I'm making, is that we need people to focus on abilities, not our disabilities. Please hear us. And if we can make it clear that we are willing to engage with people in this particular way, then I think that we will achieve the other goal of helping people talk about this much earlier in the disease, and that we can encourage people to get a much earlier diagnosis if they don't have to be so afraid of it. So in closing, I take my words from the words of people living well with dementia. Please see me. Please see us. Please hear our stories. Let us tell them in our own way, in our own time, and for our own reasons. And the last time I gave this talk, I stopped there. And a caregiver in the audience came up and said, would you please change that slide from see me to see us? And I said, I'll add it. Because not everybody has an us. And I wish they did, but everybody doesn't. But to all of the care partners as well, I do see you, and I do understand that dementia is a condition of families, of partners, and I would like to listen to their stories in their own way, in their own time, and for their reasons as well. In closing, I want to thank you for being here. I actually went a little too fast to tell you that when Dr. Saeed makes the slides available, you will have some very select resources and references I call to your attention. And I call to your attention a great poster I just saw during lunch about OT interventions, and another one of my junior colleagues, Quinn, and her colleagues get a shout out for it, because it tells you all the practical things I didn't, because I'm not an OT. I'm telling you how to talk to me and how I hope to continue to talk with your people living with dementia. Thank you so much for your kind attention.
Thank you, Dr. Weary, for this amazing presentation. So now we will be having a presentation that talks about the importance of play in the pediatric population in children. And the presenters, who is my wife, Elizabeth, and Ina Rosen from Germany.
But there's play throughout all of it, right? It's working now, right? Can you hear me? Okay. So welcome to our presentation. I'm from Germany. Elizabeth is from the States. And it was very interesting to work together on it because we're so on the different angles of the world and meeting here in Morocco to see you. So we were thinking, what can we add to your knowledge? Because I'm from Germany, she's from the States, so we're talking to you about play, and what do we know? So let's just say, we talk from our experience as occupational therapists who are both working with children, and of course, play with them. And we just share our thoughts about it. And we would love to hear your thoughts, but we just have 15 minutes, so maybe we can do that later in another break or at dinner. So first, we like to know who of you works with children. Just lift your hands. So a couple of people work with children. Who of the students wants to work with children once you're ready? Yay, that's the future. Who has children? Okay. And who is still a child in their heart and loves to play? Okay, so I think we are getting there. Yes. Okay, now we need to. So we skip the objectives and look at play. So what is play? I think we all know or have something in mind when we talk about play, but do we have the same thing in mind? And when I looked up the literature, I found so many different definitions of play. They are like all over the world. Some people describe play and it's not the same. So we thought about it, what really is play for us as occupational therapists, but also for us as mothers and as human beings. So let's see if you agree. So first, we thought as OTs, play is a driver of learning in early childhood. So through play, children learn things. But also we thought it's a window into the child's development. So when children play, we can have a look at them and think, what can they already do? So we all do that in practice, I think. So we use play as a means of an occupational therapy intervention. So to reach another goal, Elizabeth is going to give more examples of that, but also play is an aim of an occupational therapy intervention. So we want the children to be able to play, because play is a central occupation in every child's life. And I think a very important part, it's every child's right to play and to have fun and to be a child, even though not all children in the world do have time and space to play safely. So, play is important for health, development, and well-being. And let's see what play does look like. So I want you to think back to your own childhood. What did you play? What did you love playing? With who did you play? With your mom, your dad, brothers, sisters, friends, your grandma, maybe your granddad? With what materials did you play? Maybe stones, sticks, or did you have games, or a ball, or I don't know. So I think you all have memories, and it's very deep inside your heart. So play all around the world looks a bit the same. So if we see children playing, we will recognize it's a game or they're playing. So for those who are traveling and just came to Morocco, did you see children in Morocco play? I know because I talked to some of the people. So yesterday I walked through the street and we were at the playground and I saw all the children playing with the parents, and I really like observing children play. It's just so joyful, and you can always see that people from different cultures do play. So all around the world, children do play. They engage in playful activities, even though not all cultures allow children to play. So sometimes it's not appropriate behavior to play in certain situations. Not all cultures support children in playing the same way. So all children play, but there is a cultural variability in children's play. We decided to take this map. Some of them here in the audience are smiling because I know some even maybe did not notice after lunch that the map is upside down. So what we want to say is play is unique to where you are in the world, but also play is unique to every child. So not just for every country or culture, but also for every family, every single child with every different ability. And Elizabeth is going to show some very nice cases of how different this can look and what play can look like with different abilities. So there is a strong relationship between play and culture does really play a big role in how play looks like, and also how we as adults encourage children to play, what values we emphasize them to experience during play. So research shows that European and American mothers emphasize independence and self-expression in play. But Asian moms do encourage social harmony and respect for rules. I thought that's very interesting because I'm sure we agree that social harmony is very important. So our adult beliefs and our culture can be seen through play. So just have in mind what is your culture or the culture of the child you're working with. I do have Moroccan children in Germany who come to occupational therapy as well. So I also need to think what is important for them. Even though they are in Germany, I'm German, but still the Moroccan culture is important for them.
And so, because we have so many students in the audience, I thought it was really important to just stop for a second and look at the science of it, and just stop and think through how the body function and structures are where we're framing play, and that play is then influencing the sensory integration development. We believe it influences the physical development, the cognitive development, and the language skills. As we know neurodevelopmentally, with our physical growth pattern, it's sequential, it's predictable. There's a pattern there. And we start with that whole cephalic dichoidal, the head to tail development, and our proximal to distal development. And then from just a generalized stimulus base, and then we're going for like a goal orientation, and we're reaching for things. And to stop and think through, there's been movements in America on things called tummy time, for example, where we encourage children to lay prone on their stomach when they're very young because it puts them in positions of the symmetrical tonic neck reflex, and it helps their bodies develop. And so I just wanted us to kind of think about the science briefly, and then I'll get into the good stuff. This is not behaving. Just relax. Okay. And so, occupational therapists, we're here to support children with all levels of development, I can't walk, and abilities to participate in play. And so whether it's helping, the parents and the teachers adapt and modify, whether we're helping come up with tools and toys to use, focusing on changing the environment or the activity and not the child. How could we set this up differently? How could we make this more accessible for everyone in the room right now? And then something I feel is so valuable that really gets ignored quite often is actually giving the child protected time for play, that this is a part of your childhood, that, my husband will tell you stories of when he was sent down to the Ferran to take the bread to the oven in the community, and then those few minutes of when, nobody's looking and he gets to stop and play kora, play soccer in the streets with his friends on the way back from having delivered the bread, that there's times built into your schedule in your childhood. These are some friends of mine. This is Suhaila. She's 3. She has CP up in the top left corner with her mother. And she's in the clinic down in Marrakesh, and they were happy to share the pictures to share with you today. And Suhaila was working on getting her stability for sitting and for socialization. And so her mother and I worked with playing and sitting on her lap and teaching mom how to support her as she's getting older and heavier, and being able to sit up and look around and enjoy the world instead of being left, nicely, cleanly swaddled and comfy, but maybe over on the couch in the corner. In the middle is a picture of my student Kayla. She has Angelman syndrome. She's a student I work with in the United States. And Kayla, as you can see, puts everything in her mouth. She's very good at that, and she loves it, and she loves that oral exploration. And so it was very important for the teacher to know that Kayla could play independently, but safely. And so we came up with a variety of toys, and some of them are mounted to the wall so that she could pull at them and engage with them, but not actually, get harmed by them. And she just is going to town. And so it's just fun to see her get to engage at that level. And as Ina had mentioned, United States Play is about independence in part. And that was very important to her teacher, that she was getting that time to be independent. And then the last little friend, Imran, is with me down in the mirror. And he is 4. He has CP and developmental delays. And we were working together on, again, positioning and balance, but he was reaching, and he was intentionally grasping. And the physiotherapists that we had been working with at the clinic, who are incredible people, had wanted to get him through his stretches, and had, in all good intentions, had mom hold her cell phone above his face while he laid on his back on the mat to watch YouTube videos of music so he'd stop crying for therapy. And that was, you know, they're really good problem solving that they came up with. But the second we got him off that mat and got him upright and got him looking in the mirror and playing with himself, he didn't need YouTube to distract him from his body, and he was engaging. And what we understand about the body and neurodevelopment, that ability for him to volitionally, to intentionally engage in that changes where we're going with the therapy. It was very powerful. And we both had a really good time that day. And this is an example of tummy time. This is a picture off the internet that I really liked about the prone belly and how nicely that play is adapted in a way that is something that we could all do here in Morocco quite easily, I think. I did throw in a couple resources so that if you need things to hand out and show to your clients here in Morocco, one is our AOTA tip sheet that I really like that talks about play. It's a nice handout to give to parents, and it's a nice handout to have for your colleagues. It's not been interpreted yet into Arabic, who knows? And then this is the CDC, the Centers for Disease Control in the United States. It's just a really nice developmental checklist that SIDE was part of the translation project for, that they finally just got translated into Arabic. And I think that I'm sure you have many resources in Arabic, but I know what this one says, so therefore I felt comfortable sharing it with you. And it's been translated to a lot of different languages too. So I want you to be able to have some resources when you leave here today to be able to look at more things. I think what was really important to us today is hopefully you've got some new ideas, some creativity and passion has been sparked with this presentation. We hope that you understand why play is important to all children, right? And that children with any kind of ability is being included in the play process. And that maybe you got something useful to implement for your professional or personal life, and feel free to contact us. Thank you.
Thank you very much, Elizabeth and Ina. So our next presenter is Nadine Blankfort, and she is from Canada and the Netherlands. Unfortunately, she could not be with us, but she shared with us her amazing work via a recording presentation, and we will be looking at it shortly.
Hello, everyone. First of all, I'd like to apologize that I'm not able to be with you there today. I would have loved to be at this really exciting conference, but unfortunately, I wasn't able to make it. But I feel very lucky that I am able to present to you in this online format, and that we can hopefully start the conversation about occupational therapy with displaced persons. My name is Nadine Blankfort, and I have studied occupational therapy and global health. And I'm currently working at the Amsterdam University of Applied Sciences. And there I work as an international coordinator. And I also work as a PhD researcher studying refugee integration programs in the Netherlands. And today I'd like to share with you a bit of the work we've been doing in the Occupational Therapy Europe interest group on displaced persons. And I would like to share you some insights from refugees themselves on what they think occupational therapy could mean for them. So first, I'd like to look back at the history of occupational therapy and why it is that we would even be a profession suited to take on a role working with displaced persons. When we look back at our profession, there is one important site, and that is the Hall House, which was a settlement home in Chicago for new migrants. This was a place where they could go to build a social network and to gain skills that would be important for their new life in America. And the major concepts underlying the development of the Hall House, which later underlined the development of occupational therapy, were that it was a social and a critical profession, and that it was focused on communities and not only individuals. And Jane Addams was the founder of Hall House and later became the president of the National Society for the Promotion of Occupational Therapy. So just as the Hall House focused on working with migrants, I believe that working with displaced persons is not an emerging practice, as some call it, but actually a re-emerging practice, as it's taking us back to our roots. So if we look at human displacement, we see that there are millions of people who are currently suffering from displacement. And these people are often displaced in their own countries and also across borders. And they are fleeing for many different reasons. Of course, because of national and international conflict, but also because of persecution, food insecurity, environmental catastrophes, climate change, and economic insecurity. And we see that in the European context where I'm working, we have a restriction in border crossings. And because our borders are becoming more restricted, we see an increase in human trafficking and human smuggling. We also see that the burden for managing refugees in Europe is falling mostly on the southern European countries, because we have a rule that the first place where refugees land is also the country that has to process their refugee or asylum application. And if we look at human displacement from an occupational perspective, we see many things that should be very concerning to us as occupational therapists. We see that displaced persons experience a situation of occupational disruption very suddenly. They have a sudden upheaval of their lives and routines that are completely new, and they're having to adjust to completely new settings. We see situations of occupational deprivation, where people are living in detention camps or detention centers where they're unable to work, play, or study. We also see occupational injustice, where laws and policies are limiting people's abilities to engage in occupations that give meaning to their lives and that help them to shape their identity. So for the last years, we have been working in an OT Europe interest group on displaced persons. And our aim was to look at what occupational therapists in Europe are currently doing with displaced persons and what is needed to advance these roles in the future. Last year, we published 3 documents as summaries of the work we have done so far. The first document was a report on what current practices are being done and the implications for the future. The second document we published was a call to action, and this was a document aimed to push forward OT education, research, and practice in order to really prepare occupational therapists to take on roles in these fields. And lastly, we developed a template position paper so that professional organizations in all countries could write a position paper which fit the local context that they are working in. And these documents, as well as other information, can all be found on our website. And here's a QR code in the link to our website. And this is a place where we hope to bring occupational therapists together and also other disciplines in an aim to share practice examples, to share knowledge, and to identify needs for occupational therapists to further develop themselves in these roles. And I will show you a little bit more about what we all have on this website. So firstly, we have a practice examples map. And this map shows all the occupational therapists that are currently working in Europe with displaced persons. And if you click on a mark on the map, you get this information that you see on the screen. You get the name of the person, their contact information, where they're located, and also what kind of work they are doing with displaced persons. And right now our map is focused on Europe, but we are also currently collaborating with other organizations on displaced persons, for example, in Canada and in Australia, We are always looking to further collaborate with other groups in other contexts. Another thing that we have on our website are practice examples. So here we have more information about OTs who are working in the field of displaced persons. You can see all the different countries people are from, and if you click on their name, you get one document that outlines more detail on the work they are doing, what approaches they are taking, what occupational therapy models, assessments and interventions they're using, or if they're using assessments and interventions from other theoretical perspectives and professions instead of occupational therapy, and also what organizations they collaborate in their work with displaced persons. So I really encourage you to take a look at our website, because not only do we have the things that I just showed you, we also have discussion forums, reference lists, calendars, and tools for educators, students, and practitioners. And if you are interested in keeping up to date on our work, you can also sign up for our mailing list. And if you are yourself working with displaced persons, you can also submit your own practice examples through website. And on the next slides, I'm going to tell you a little bit about the results that we found while we were interviewing occupational therapists to write our report. And the occupational therapists identified some important gaps that are currently existing in the field of work with displaced persons, which are important to address if we are going to continue our role in this field. So on these slides, you will see quotes from occupational therapists which we interviewed while writing our report. And the first gap that was identified by one of the people we spoke to was that there is simply not enough research done in this field altogether, which makes it difficult for occupational therapists who are starting in this field. And there are some research that is done on community-based treatments or therapy, but research on assessments, evaluations, and interventions that really allow us, as this person said, to see the human uniqueness are missing, and they are very much needed in order for us to further develop ourselves in this field and to share knowledge. The second gap that was identified by an OT working with displaced persons is that we need to look critically about how we understand occupations and activities of daily living. This occupational therapist said, "I found that occupations that are allowed, obligatory, forbidden, or gender-based are important to understand, and that this is important as part of an activity analysis." She said that we need to understand how gender rules and cultures shape activities and occupations, and question what we see as normal ADLs, as because this may be defined differently by different cultures all over the world. Another gap that was identified was related to the professional associations in Europe in occupational therapy. This occupational therapist identified that many other professions had developed position statements on their specific profession and displaced persons, and that occupational therapy was actually running behind on developing these kinds of position statements specific to the countries. Because we do not have these papers or are taking these political steps within our professional associations, we are actually missing from the discussions when they are being had of how we can work with refugees and help them integrate into new societies. The last gap, or rather advice, that was given by one of the occupational therapists was related to education. They said that students need to really understand culture first. They need to understand the background of people as humans, and only then start to evaluate or intervene. This person said that often we as occupational therapists jump too quickly into wanting to assess people or to intervene with people. And she says that students need to learn that first they just need to understand who these people are as humans when they are sitting across from us? And what did that mean for their occupational roles and what they could do here in this new context? And now I would actually like to share with you advice that was given to me by refugees themselves. A couple years ago, I was asked to write an article for the World Federation of OT Bulletin on occupational therapy with displaced persons. And I accepted to do this only if I was able to write the article with refugees. Because I saw that many of us have written articles on occupational therapy with refugees, but none of them have included the refugees' voice themselves of what they would like from occupational therapy or what they need. So I invited 4 people with a refugee background to spend 2 days at our school. And they interviewed occupational therapists. And after the 2 days, they wrote their own definition of OT and they wrote advice to occupational therapy on what role they could take with refugees. And this advice will be published in an article for the WFOT Bulletin. So this is the definition that the group of refugees wrote after interviewing OTs and spending some time at our school. They said that occupational therapy is a discipline which investigates the causes of issues in participation, confirms the desired end results of the client, and from there, together with the client, searches for solutions to these issues in order to improve participation in society. And I think this is a really nice definition of our profession. They also identified 3 roles which they felt occupational therapy could take on with refugees. The first role was a matchmaker. They said that you are a profession focused on strengths. Therefore, get to know me as a person and my strengths, and then match those strengths to opportunities in my new setting. Secondly, they said you could act as a translator, and they didn't mean in regards to language, but instead they said, translate to me the everyday activities that I need to understand in this new context. For example, one refugee said that she now in the Netherlands had to ride a bike everywhere and had to do her groceries with a bike, pick up her kids from school with a bike, yet no one had ever actually taught her how to do this. And lastly, they said the occupational therapist could be a connector. And in this way, occupational therapists could just bring refugees together in order for them to support each other and to help each other, and that the occupational therapist's role would only be to provide a space for this to happen. And the last thing I want to share with you is a warning that the refugees gave me. They said that you as occupational therapists are very focused on goals. They said we have to be careful with this, because they said that refugees are often in a system where they have no choice, they don't feel secure, and they are unable to set goals. And if people are unable to answer the question, what is your goal? They should not be seen as unmotivated. They said that sometimes you are asking someone what they want to do when they are stuck in a system that is actually encouraging them to wait and do more.
So unfortunately, we're going to stop it. But thank you, Nadine, very much. Appreciate it. It's an amazing presentation, and we have it. We will share all those presentations with you as well. Yes. Yes, I'm going to time myself, definitely. I enjoyed this, but I want it to be over. All right. Yes, it's the stress of the whole year. So the role of OT, so in America and in other countries, OTs and occupational therapy practitioners, they work in lymphedema. They work with people with lymphedema. And several years ago, actually, we saw a video online talks about somebody who's 16 years old here in Morocco has lymphedema. So lymphedema is a swelling that can happen in any part of your body. But that video that I saw for that teenagers, he couldn't go to school, and he was a very smart boy that was the lymphedema انتفاخ في الرجلين وفي اليدين وفي الفم ولا في أي العنق. And that swelling was preventing him because his one leg was massive. And he was in the region of Marrakesh. You can still see the video on YouTube, and I will be happy to share it with you. And that boy went all over the country to seek some treatment, and they didn't know what to do with him. In fact, the video, you can still see it, they call it the unknown disease. And so we contacted that boy, and we connected to the clinic in Marrakesh, an rehab clinic that we work with, and we were able to train the therapists there how to treat lymphedema, and they helped him. It's as simple as just compression. So it was something that can be easily done and accessible, but unfortunately, a lot of people here in Morocco, including doctors, don't know about it. And as I'm not trying to be mean to doctors, but even in America, a lot of doctors still don't know what lymphedema is. In fact, the medical schools in the United States, after actually a research that was done, they only teach about the lymphatic system about 15 minutes to 2 hours in the entire medical program. And that was done through a survey with all of the head of the medical schools in a conference. So the point here is that we are trying to bring this treatment here in Morocco. I know some colleagues here from that they are able to provide some kind of practice now here about lymphedema, but it's not enough for a country that has almost 40 million people. And the fact is that lymphedema has a greater connection with cancer. So if a woman has cancer and has her breast removed, there is a possibility about 40% that she will develop lymphedema. And we, the people who are going, the students and the faculty who are going with me in the trip in Rabat, we are going to visit the Jannat Association, and we are going to see some women who have their breast removed and have lymphedema. And unfortunately, they don't have a compression and accessibility compression, and they are expensive. So sometimes we bring some with us, and sometimes we teach them how to perform manual lymphatic drainage. So I know the time is short, but so edema, or what they call swelling, it's similar, and the start of lymphedema. But lymphedema is هو يعني مشاكل في الغدد اللمفاوية. والجسم ديالنا الجسم الإنسان فيه كثير من الغدد اللمفاوية. So the human body, it's full with the lymphatic nodes, and the lymphatic system, it's related also to the immune system, and it's very important in transferring the waste that the body does not need. So what is lymphedema? It's a chronic progressive condition presenting as swelling in the arms, legs, or neck. Again, it can be in every part of the body, but it can be disfiguring. Some people may have a massive leg or both massive legs or arms, and also it can interfere with daily occupations. And so in the beginning, there is mild lymphedema. It can be, as you see in the slides, it can be like a little swelling, and we should start right there and do treatment. Otherwise, it's going to be worse, and it may move to something like this. So, the fact is, if you can see here this picture, the top, the right side there, that you can see the woman, her breast was removed, and that's what caused. And that was, if that lady was provided just a sock, a compression, and her arm, she won't get to this, right? And this is also in the USA. We still have problems with this in the USA. So the cause of it, there is two main causes. There are primary lymphedema and also secondary lymphedema. Primary lymphedema are people born with it, and secondary lymphedema is, as I just mentioned, people after breast removal or maybe an injury or surgery or something that can kind of impair, that led to the impairment of the lymphatic system. If you look here, this is what you see green on the right side. That's where the lymphatic system is. It's from here to here. It's all over the body, and that's why it's get kind of affected. So there's some YouTube video here that I will you can share with you. There's how many people here, but what I want to raise with you attention. There is a type of lymphedema. There's like 120 million of in the world, and these are filariasis, and the cause of it is just an insect that kind of bites somebody, and it's kind of like let the eggs and the development of that worm there, and it spread over the system, and it takes over it. And look at the right leg compared to the left leg. It's a massive difference. That was just for the time when I was going to see how it's diagnosed. The role of OT in lymphedema, the occupational therapy, so we kind of value the occupations of the human being, and we try to use those occupations in managing some of the symptoms of lymphedema, but also we, as I mentioned, incorporating those occupations in the treatment. And I will give you some example that some of my patients we have who have lymphedema and were clients. So one of them is unfortunately he couldn't join us, and I would try to because of the time. But according to Kevin is one of people we worked with, Elizabeth and I, and he's an American, but he gentleman is in his 40s now, but he is originally from the Caribbean areas, and maybe he got there some introduction to kind of the filariasis right there because of the areas that have that has filariasis are in the, like for example India, Pakistan, and other areas that he is from. But treatment does work. So occupational therapy can help. This is actually a person we know. I know personally. This is not. This is in the Lymphedema Treatment Act website. She's actually a board member of us. And look how her legs were before and after the treatment. So if you do compression and treatment, the swelling can be massive, less than how. So this is just for the therapy. So as I mentioned, the cancer, people with cancer, they are at higher risk for lymphedema as well. And in America, unfortunately, even in America, we still have some problems of the cost of the compression. So the compression, if it's custom, it may cost up to $500 or more. And the insurance does not pay for it, but that doesn't make any sense they will pay for people to go to the hospital with infection, with problems, $40,000, $30,000, but they don't pay for $500. So I'm part of a great organization. I'm a board member of the Lymphedema Advocacy Group, and we're trying to convince Congress right now in the U.S. Congress. The most co-sponsored healthcare bill in the USA is this Lymphedema Treatment Act that we introduced to the U.S. Congress, and hopefully will be passed. It's already actually passed the healthcare bill, but we're trying now to have it passed in the Senate, U.S. Senate. This is my patient or my client, Kevin, and the one in the middle is Congressman Jim McGovern, and he's now the chair of the Rule Committee in the U.S. Congress. And so I called him, and we went and spoke to him about the importance of supporting us in advancing this bill as well. Every year, AOTA does kind of a Hill Day, and AOTA played a big role also the American Occupational Therapy Association does every year, the Hill Day, where we go to the US Congress and we talk about some healthcare bill, and we meet with senators and congressmen offices, making sure that we have to can advance bills in the US Congress. And I had also the pleasure to present about this at the Harvard University Medical School in a lymphedema symposium, where there is awareness about Lymphedema Treatment Act as well. And I had, if you know the one on the left side, Kathy Bates, yeah, she was actually our keynote speaker. She's a famous actor, the one on the left, and American Horror Story. And and so I was able to, she was our keynote, but she's now leading the way also because she was diagnosed with cancer and she developed lymphedema, and she wears compression all the time. The one on the right is actually a famous person as well, who is, was in the American Bachelorette, ABC, and he's very handsome, that's why he was in Bachelorette. All right, not me, okay. My wife will kill me anyway. But, so, the Lymphedema Treatment Act, it's actually, he's a big supporter of it because he almost lost his leg. And the reason was because he had lymphedema in his leg, but nobody knew about it. He was scheduled to have an amputation, have his leg cut, amputation. And 2 weeks before the amputation, somebody told him, go to Boston Children's Hospital in Boston. And he went and they told him, you know what, you have lymphedema, and because your lymphatic system in the stomach area is impaired. So they did some compression and stuff, and now he's okay. And you know, I don't think he will make it to the Bachelor show. He was with the amputation. Yeah, exactly, he should, but all right. So in America, you have to do about 150 hours of training to be certified in lymphedema. And Elizabeth, my wife, and I, we are certified in America to do lymphedema therapy. It's 150 hours, as I mentioned, and we train to do lymphatic drainage from the top to the bottom, arm and legs and everything. And so these are some of the equipment that are available in the USA to do this. And this is a slideshow that some of the pictures was shared with me with my colleague or my friend, also Eric Johnson, who is the head of jobs, director of the head of jobs, which is a compression garment. And he always give me products for free, and I'll bring it here to give it in Morocco. So thank you, Eric. All right, so for the respect of the time, I will stop here. Okay, Hajiwi, I kept the time. All right, so you have to do like me. So I know it was quick, but please, at the end, if you want to learn more about lymphedema, reach out to me or email me, and I will be happy to help you with that. But at the same time, let me get this. All right, so Safia, bring the helmet. All right. All right. So I am very honored to present you some two girls that I don't know. Safia Nafa or Mina Nafa. They started an organization in the USA. It's called brainsaves.org, and they bring helmets from the United States and donate them here in Morocco because there is a and Dr. Fortasi can tell us more about this. She did more about presentation about this last year, where there's a lot of brain injury in Morocco, and the reason is because people do not wear helmets.
Assalamu alaikum. I'm Sophia, and this is Minna. Thank you all for being here and supporting my parents. I'm really happy to be here. My sister and I created brain saves in 2017 after I fell and hit my head while wearing a helmet because my our conscious and constant OT parents made me. So I was ice skating and I fell and hit my occipital, and that was 4 months of my life having a concussion. That was really hard. So after that, we decided to create brain saves in honor of also our cousins that Minna talked about.
Hi. So after a few weeks that my sister had the concussion, we found out that my cousin had passed away because of a motorcycle accident. He fell and wasn't wearing a helmet. So, yeah.
He lives in Morocco.
Yeah, he lived in Morocco. But, yeah.
So we decided to honor him and create brain saves because people in Morocco don't know the importance of them. And I think that it's really important to bring, because helmets might not be cool, people might not see helmets as cool, but nor are TBIs. So I think that you can suffer wearing a helmet. So Brain Saves brings helmets to low-income families and children who either don't have access to them or are trying to, or can't afford them. So we're trying to restructure that stigma that helmets aren't cool and make them cool, because children should be safe, and the importance of play and being safe go hand in hand. So I host a helmet drive at my high school, and we for new or used helmets, and we bring them here, and we split the donations between Worcester and Morocco, because Worcester is a very, very close place to our heart, and Morocco is because it's our heritage. So please feel free to look at our website, brainsaves.org, and thank you very much.
And thank you to all those who also donate helmets to us to bring here, University of New England. Thank you, Chris, for bringing those helmets, and thank you for some of the students who brought also some helmets. So now, thank you. So now we will be delighted to have Naima Swedi and Osima present their presentation. And they are from Morocco/Spain. They are two OTs who practice in Spain, but they are originally from Morocco. Let me get your presentation. Which is the presentation?
Yeah, that's it.
So, Osima is going to talk in English. No, Spanish. Okay, you're good in English. Come on. Huh? Okay, but you speak English. Come on. All right. So, but they will have a translator here in Spanish. Okay. In English. So.
Assalamu alaikum. Bonsoir. Hola, buenas tardes.
y ya está. Bueno, nuestro trabajo, yo soy Naima, ella es Susima, y nuestro trabajo va sobre Morocco, Culture and Occupational Therapy, Maroc, Culture et l'ergothérapie. Los contenidos que vamos a tratar son la definición, el impacto de la cultura en Marruecos, de la cultura marroquí, perdona, en la ocupación, en la terapia ocupacional, el análisis básico de la ocupación en Marruecos y la necesidad de la adaptación y validación de los instrumentos de validación, de valoración. Primero vamos a empezar con la definición del impacto de la cultura en la terapia ocupacional, creyendo que es un sistema, la cultura es un sistema compartido de significados que abarca ideas, conceptos y conocimientos. Incluye creencias, valores y normas que forman los estándares y las reglas de comportamientos por la que la gente se rige en su vida cotidiana. En relación a la cultura y la salud, en cada cultura la concepción de la salud se articula en 3 áreas. Primero, el mantenimiento del cuerpo, la representación imaginaria de la enfermedad y otras prácticas relacionadas con la higiene como fuente de la salud. En esta definición nos lleva a otro concepto que pone en juego la salud y es el cuerpo. El cuerpo, según Flores, es un escenario de construcción social y cultural vinculado a un contexto y por eso el cuerpo deja de ser solamente una realidad biológica a ser también una realidad cultural. Hay que superar las ideas occidentales, etnocéntricas y universales únicas del cuerpo humano. Hay que considerarlo como un escenario cultural privilegiado. Marcela, por favor.
Overcome the Western ethnocentric and unique experience of the human body. Today, we must consider it as a privileged cultural scene.
Gracias. Sin embargo, el cuerpo en su relación con la enfermedad se reduce a lo que es la biología y la anatomía, deja de ser lo que es la cultura y la sociedad. Entonces se despoja del contexto cultural.
So, however, the body and the relationship with the illness reduces one's autonomy and one's biological configuration. In addition, one loses its relation with its cultural and social context.
Thank you. Así que, en definitiva, podemos decir que el cuerpo es el territorio donde cada cultura inscribe, graba y forja sus nociones de humano, persona o individuo. Es la superficie para la estructura de cada cultura y la metáfora expresiva de la sociedad que lo produce y lo inscribe. Inda Zango y Pedro Miralles llegaron a la conclusión y la afirmación de que los terapeutas ocupacionales debemos comprender la cultura considerándola determinante en nuestras intervenciones. Estamos ante una disciplina profundamente etnocéntrica que urge la incorporación de la interculturalidad y la antropología médica para una terapia eficaz. También han observado que la mayoría de las fuentes bibliográficas provienen de poblaciones localizadas en las áreas urbanas de los países anglófonos de Occidente. Esta cifra ronda alrededor más o menos de unos 17%. El objetivo de nuestro trabajo es principalmente concienciar sobre la importancia de conocer y determinar los factores culturales que afectan de forma directa en nuestra praxis y resaltar la necesidad de adaptar y validar los instrumentos de valoración, para la realización de una terapia eficaz, efectiva y intercultural. El segundo punto que vamos a tratar es el análisis básico de la terapia ocupacional en Marruecos, más bien de la ocupación. La cultura marroquí es una cultura muy antigua, Tiene mucho bagaje histórico, tiene muchos dialectos, 2 lenguas oficiales, el árabe y el bereber, otra lengua parecida también es casi oficial, que es el francés. Se basa en leyes tribales, espiritualmente eso es muy rico, costumbres mágicas, tradicionales, medicina tradicional, y todo esto está relacionado con la religión. La religión en Marruecos es un instrumento que da legitimidad a las ideas, acciones, leyes y prácticas. Mi amiga, mi compañera, os va a explicar más profundamente.
Hola. Ok, vale. Bueno, entonces la religión gobierna y guía las ideas, las leyes, las prácticas, las actuaciones, incluso divide los espacios en públicos y abiertos, que son generalmente la calle, que es la esfera de los hombres, y la esfera privada, el interior, el hogar, que es la esfera de las mujeres. Según la encuesta realizada por Burkia, el 97,3% de las personas encuestadas afirma que el Islam ofrece respuestas a sus necesidades, y el 99,8% asegura que el Islam ofrece confort. Y en otra encuesta, la encuesta nacional de valores, el 72,4% asegura que reza regularmente. Por lo tanto, la religión está muy presente en la sociedad marroquí. De tal manera que influye en las relaciones sociales, en el trabajo, en el ocio, en las actividades de la vida diaria y en el espíritu. De esta manera influye también en la ocupación y en el significado de la ocupación, siendo esta universal y al mismo tiempo individual. Todos podemos realizar actividades de manera similar, pero el significado que le damos es personal. Y un ejemplo de ello es, por ejemplo, ir al hammam o a los baños árabes, que para algunos puede ser una actividad básica de la vida diaria, para otros una participación social, para otros una actividad de ocio. Ir, por ejemplo, a los hornos a llevar el pan, conlleva una actividad de la vida diaria que sería la cocina, o también es un espacio para la participación social. Lo mismo pasa con ir a la mezquita o en la casa del Corán, pues es un área donde se lleva a cabo la educación, puede ser un área social de participación, ocio o incluso de juego. Por lo tanto, lo que queremos poner de manifiesto es la necesidad, sobre todo a las nuevas promociones de terapeutas ocupacionales que van a salir, de adaptar y validar los instrumentos de valoración al contexto cultural, ya que la Organización Mundial de la Salud asegura que validar los instrumentos, es necesario validar los instrumentos de valoración en el ámbito de la salud para tener para poder realizar estudios comparativos a nivel internacional, tener indicadores de salud estandarizados y tenerlo como apoyo en el ámbito clínico. Porque una valoración o una evaluación fuera del contexto hace que las intervenciones terapéuticas no tengan en cuenta las realidades del individuo ni la significación. Por lo tanto, la profesión pierde la capacidad para contribuir en algo positivo en la sociedad. En definitiva, es necesario tener instrumentos que den garantías para tener una adecuada valoración, es decir, que estén validados, que midan lo que realmente tienen que medir y que estén adaptados al contexto cultural. Y un ejemplo de ello es el índice de Bartel, que, que lo que hace es valora el desempeño de las actividades de la vida diaria. Nos hemos enfocado en 2 ítems, por ejemplo, la alimentación, que en los países occidentales se utilizan los cubiertos y en la cultura marroquí se utiliza la pinza tridigital o comer con las manos. Entonces, es un ejemplo pues, a tener en cuenta a la hora de adaptar. Y bueno, esta es la bibliografía y gracias por su atención.
Thank you very much, Seema. Naima and people who helped in interpretation of this presentation. So next we will be having Dr. Hajiwi, who is a physiatrist. Okay, okay, go. And his presentation, it's 10 minutes, and I'm going to be standing next to him. No, start later, yeah.
Quickly. Computer. This one.
وهذا ديالك. Okay.
Thank you, Said. I am really happy to be here today and to share this experience with OTAN, Moroccan Association of Occupational Therapy, from 2016 and just today. It was a dream in the beginning, and now we can say the successful conference, second conference. And I would like to thank all the people working to improve rehabilitation and OT in Morocco. My talk is about rehabilitation needs for Morocco 2030, a call for action. So I try to explain why we should take an action and why we should work together to improve rehabilitation for Morocco in 2030. I skip this slide. So Morocco faces big new challenges in health and demographic situation. The first one is the epidemiological transition due to a growing burden of non-communicable disease. The second one, demographic transition because our population are aging. The third one is nutritional transition due to growing risk of obesity. And the last one is the social transition because we should adopt the universal health coverage. Here we can say the growing burden of non-communicable disease if we compare between Morocco here. If we compare the burden of non-communicable disease with the communicable disease and the situation in the world, so we have more and more the global burden of non-communicable disease. Also here we can say that we have a dramatic decrease of premature deaths due to non-communicable disease. So we have now more and more survivors with disability. And here we can say, we can say that the adjusted disability adjusted life year is decreasing between 1990 and 2018. So we have more and more people living with disability. In the other hand, we have the increase of years lived with disability from 1990 and 2018 in the world, but specific in Morocco, the number is more important. So in our epidemiological, transition, we have a growing burden of non-communicable disease in Morocco, a dramatic decrease in the number of premature deaths, dramatic increase of the number of years lived with disability, raising prevalence of disability, and decrease in the number of disability adjusted life years. So we have a lot of demand for rehabilitation services now, and we should prepare to more and more demand in 2030. In the second transition, we have demographic transition. So we can say here that the average life expectancy in Morocco is growing from 42 years in 1950 to 74 years in 2014. And our population are aging, and as you know, there is a relationship between disability and aging. And we can move from the prevalence of disability for children under 15 years old of 1.8 to 30.7% for people over 60 years. So we have a lot of people, aging people, and we have more and more disability. What is the major risk factor of non-communicable disease in Morocco? We say here the last survey conducted and published by WHO in 2018, and we can say that 1/3 person in Morocco suffer from blood pressure. 1 of 5 person in Morocco don't have enough physical activity, and 1 of 5 suffer from obesity, and 70% smoke in Morocco, and 10% they have diabetes. And when we compare between the national survey in 2004 and 2015, we can say that the prevalence of disability is increasing, and we can estimate that in 2020 we have around 10% of people with disability in Morocco. And now we can say that we are moving as government, Moroccan government, to the universal health coverage, and we should develop rehabilitation as part of this package of universal health coverage. So we can summarize the situation in Morocco. We have the decrease of mortality, increase of aging population, increase of non-communicable disease, increase of prevalence of disability, and we need more and more of rehabilitation services, and not only reduce mortality and morbidity for our health system, but also improve functioning and well-being of the population. We should take a lot of opportunities that we have. The first one is the Convention on the Rights of Persons with Disability, ratified by Morocco in 2009, especially in this article 26, called on member state to make rehabilitation available at the earliest stage and make rehabilitation services available as close as possible to people's community, including in rural areas. The second opportunity that we have, that Morocco adopts a new constitution, and in this constitution we can say a lot of articles talk about access to healthcare as a fundamental and constitutional right, and we have a specific articles talk about access to rehabilitation for people with disability. So we have this opportunity and we can use it very good. Another opportunity is our national action plan. For the first time in our history of health system, Moroccan health system, we have a national and health disability and action plan, and we have 2025 health plan, strategic plan. And in this strategic plan, we have specific actions and measure about rehabilitation. So it's also opportunity. We have also some documents from WHO, a call for a recommendation for strengthening rehabilitation in health system. We have also the sustainable goal of development. We have also this guide for action from WHO. And of course, we need a global rehabilitation alliance. This is the photo of the International Global Disability Rehabilitation Alliance. We can see here physical rehabilitation doctors with the PT. Here, this is Samantha with the OT, with all the rehabilitation team. It's the why and how we can make rehabilitation strong in Morocco. We start with Said. It's a very nice experience to work rehabilitation, physician, and OT, and we need all the member of a multidisciplinary team, PT and speech therapists and all. So I can conclude to respect time. It's time to act. And as the one speaker say, we have our future on our hand. So we can work together. And thank you for listening, for your attention. Thank you.
Thank you, Dr. Hajiwi. Dr. Hajiwi is one of the biggest supporters of OT in Morocco, and it's an honor to work with him. Next is my dear friend Monique, Dr. Monique Chabot, who is very familiar with Morocco. She has been here 4 times helping to spread OT in Morocco. And she will talk to us about dementia.
Thank you for that introduction. I would like to share with you an intervention that I used with a client of mine in late-stage dementia who I was seeing honestly for contraction management, but ended up being really important for reducing agitation and combativeness in her daily life and improving her quality of life. So as we get started, I'd first like to introduce you to my friend Aloise. At the time that I met her, she was 98 years old. She lived in a condo with a 24-hour caregiver, and her son would come and visit pretty much every evening, but he had a very busy career as a lawyer, so she had a caregiver with her at all times. And the reason why I was out there in the first place was because she had a left-hand contracture. Her hand looked like this, and they were wanting me to come out and fix her hand, especially since she was getting that characteristic fungal bacteria smell that, quite honestly, you'll never erase from your memory once you smell it. And she was also extremely sensitive to touch in that hand. On top of all that, she sat on the couch all day. This is what she looked like. Full cervical flexion, was legally blind, very, very, very hard of hearing, had no interaction really with the outside world whatsoever. So you can imagine that working on a hand that's already very painful was leading to a lot of pain, a lot of confusion, and understandably a lot of agitation, because wouldn't you be scared and hurt and confused as well? She could follow one-step commands about 25% of the time if I was lucky. At that point, she had total ADL assistance with some agitation and very frequent verbal and physical outbursts. So for those of you who need a refresher, or maybe you've never seen this before, people who are in late-stage dementia, specifically stage 6, transition to needing full-time care and total assistance with their ADLs. they do start exhibiting aggression, agitation. They would call them combative behaviors, most of the time because they're just scared and not understanding what's going on. They do have personality changes and decreased initiation in terms of tasks and motor planning. Eloise definitely had 90 seconds of processing time where I had to wait that long between commands or even speaking to her for her to understand what I was saying. Those postural changes, and her eye gaze had already shifted down to be about 2 feet in front of the floor. So if you can see that black plaque on the stage, that's where I would have to sit so that she could actually see me while I was working with her. I wasn't some discombobulated figure coming in and stretching her hand. Let me share some of the research that informed my intervention before telling you how I kind of decided to pull all this together. So sensory stimulation is used in long-term care in the research. They use them for Snoezelen rooms and also multisensory stimulation techniques, which usually involves music and aromatherapy, maybe some light touch. And they find positive short-term effects in terms of increased communication, increased ADL engagement, decreasing agitation, and increased mood. And short-term is better than nothing. I also knew of the Tailored Activity Program, which is actually in the home, and what they were doing in the Tailored Activities Program was reducing dementia-related behaviors by prescribed client-centered activities that would be done before a difficult ADL. And these could be some kind of sensory stimulation, it could be a craft, it could be anything that was meaningful to the person to increase arousal, to increase engagement. And fortunately, it was designed for home care and found to be effective. And a quiet book is actually something that's typically done for children. And I'm not saying was treating Eloise like a child. It was just more of how can I create something portable that combines all these principles into her home, and you'll see why in a second. But they have interactive elements, they're often educational, they're soft, and they have bright, bright colors that are easy to see. So when I was working with her, there's 2 things I noticed. And these are the times where she was a little less agitated when doing a task. One was that when she was smelling lilies, like the Asiatic or Easter lilies that we have, she could smell them, she would comment on them, she'd be calmer for the entire session. Other thing I had noticed was that she was doing a toilet transfer with her aide, and I was watching to train her aide, obviously. Her aide was wearing a white scrub top with bright, bright neon flowers, and this was the only time I'd seen Eloise do anything with anyone where profanities weren't being spewed right and left. She was so calm, and she was transfixed by the flowers. She was about this tall, and the aide was about my height, and so she's staring at those flowers and just commenting on how pretty the flowers. They did all the toileting from start to finish, the transfer, everything, and Eloise was cool as a cucumber. So I thought, how can I tap into that and make a difference, at least if nothing else, make an impact on her daily life, even if I'm not getting anywhere with her hand. So with her book, it was bright colors on a black background. She was legally blind. She needed those bright colors and that strong contrast to see anything. I interrogated her son for a little bit and found out all the things that she had loved to do. And I was getting bits and pieces of it as I've been working with her. Eventually, when I told him what I wanted to do, he opened up a little bit more and shared a lot of her past activities. I also tried to build in other tactile input. I was hoping that her ability to motor plan and reaching and touch wasn't completely lost. Unfortunately, it was, but I had wanted to give her other opportunities to explore and move her hands and do range of motion. And she happened to really love to count for some reason at that point in time. So there were a lot of images so that she could count. And you can see my materials here. There's nothing fancy. At the time, I put them all together with hot glue. I didn't pull out my sewing machine until later. So it really was not expensive and nothing fancy whatsoever. So here's a page. This was her absolute favorite page. It turns out she was an avid bridge player, and she spent many hours just counting these cards. And the book looks big in the picture. It actually really wasn't. It was like this big. And she would also count the little designs on the inside. She also loved the flowers. She really, really loved flowers, and so that was another favorite page. They had pom-poms on them, so I was really hoping she'd want to reach out and touch them, but she just really couldn't. She was past the point where she could motor plan that, unfortunately. And her fingernails were still really sensitive, so that was still enough to kind of make her upset. The moons and stars, I was just trying anything. This was a complete Hail Mary kind of intervention for me. I just wanted to see if it would work. She really didn't care about the moons and stars. It had no connection to her life whatsoever, so the cards and the flowers were the way to go. So what we would do is I would put it on her lap prior to ADLs to increase her arousal. I'd sit on that floor, rub her knee, and we'd do it that way. We also would use it to have her look up and stretch out her neck. We used it for social interaction through counting images. It was a way she could interact with her caregivers and her son and with me that was meaningful to her, that wasn't confusing or painful for her. We did encourage the page turning, 25% success rate on that one. And I was also using it for distraction during contraction management. So you can see everything that kind of happened, but I'll just tell you the story of the first time I gave it to her. So I brought the book in, sat down on my place on the floor, touched her knee, woke her up, put the book on her lap, and when she opened her eyes, she looked at it and all of a sudden just went, wow, big smile, said, what is this? And I told her it was a book I made you. You made this for me? I did. Do you like it? Wow, look at that, thank you. And then she actually looked and made eye contact with me for the first time and started asking me about where I lived. I just so happened to live in her old neighborhood in Philadelphia. So I said that name. We had a 30-second conversation, which I'd never had. I've been working with her for almost a month at this point. And then she closed her eyes. I turned the page, woke her up again. We had that same conversation. The entire time, I'm very slowly stretching her hand and sliding a towel roll in. I'm sneaky like that. Excuse me. So, and it really decreased her agitation, and her aide was just flabbergasted. So was I, honestly. I found out later that night, it was the first time she tried to feed herself in over a year. And she started standing longer, doing toileting, standing longer during lower extremity dressing, being a lot less agitated. And when she wanted to talk to us, even to me or anyone else around her, she was a lot less agitated in her tone of voice. I think she recognized that people were around, and she was actually starting to be able to communicate when she wanted something to drink and other things with words instead of just screaming, which is what she was doing at the time. A year later, when I came back to see her for another reason, they were still using the books. They found them to be very effective in decreasing agitation. She loved the flowers and the cards, and I made her a couple different books, but those 2 pages were still the favorites. And it was part of her daily care plan with her caregivers. And when she passed away just shy of her 100th birthday, when her son called me to tell me the news, he wanted to give me back the books because he wanted me to give them to someone else. And he said that they were single-handedly responsible for improving her quality of life through the end of her life, and that gave him a way to talk to his mom as she was on hospice. Oh, it's that Windows thing. There we go. So a few tips for you guys if you want to try this. You can see the conversation I had with her about the fish. She said, what's that? It's a fish. It sure doesn't look like one. And to be honest, touche. So don't take it personally if somebody makes a comment about your artistic abilities. You don't have to be an artist to do it. As you can tell, I am not. But simple is often better. Also because it's easier for people to process visually if it's a simpler page. I had made her a beautiful 3D book at one point with 3D daffodils, which I'm still proud of, and it was still not her favorite. She liked the simple pages. I made Matisse cutouts for someone else, actually. She was an art collector. And the couple pages that I have to say were pretty good, she started talking about colors and movement and things I hadn't heard her say in almost a year. The next page that wasn't so good, she told me it looked like a kindergartner had done it. And so I was like, all right. As you can tell, too, though, the past occupations were really what really got their attention, which goes in line with all the evidence, but also with what we stand for as occupational therapists. So you really want to use those things. And I think, too, the context of it being a book, those buttons are actually on elastic. I wanted her to pull on them, but I think the context of it being a book meant you don't interact with it that way. So you have to be very aware of the context of what you're giving and how it's being interpreted. But other than that, being really intentional with what you're doing, but it doesn't have to be expensive, it doesn't have to be complicated. Actually, sometimes simpler is better. If you want more information, you can feel free to email me whenever you would like. If you want to make your own, this is where I got my inspiration from. You will see a lot of children's books, that's what they are. But they have some really cute ideas that you can replicate if it's appropriate for the person you're working with. Some references, and my final acknowledgement for this. She was a fieldwork student at the time that I was working with Eloise, and she deserves some credit for all of this. Thank you.
Thank you, Dr. Monique. Thank you. All right, next one is Dr. Inda Tsango, and she will be giving her presentation. It's also 10 minutes. I already warned her because the tea is waiting and the coffee.
Salam alaikum. Lavas. Ça va, j'espère que ça se passe bien. Good afternoon, I hope you are doing well. Y buenas tardes, everyone. First of all, I would like to thank Said and all the team who has done possible this encounter because they offer us the more richness thing that human being we have is time. And thank you so much for your time, and thank you also for you that you are also sharing with me your time in this sunny afternoon. Well, I will so sorry because my level of English is not so good, but I will try to do my best. And usually I speak in French or Spanish, but I used to go to Sweden to teach in an intercultural course, and there I try to use English, but please let me know if something is not clear. I would like to share with you some reflection about OT culture and the need to listen other voices. Because usually when we talk about culture, we used to talk about others culture. And there is so many studies in occupational therapy focus on how people from different or diverse backgrounds are engaged in different occupations, but probably we are not so deeply developed the knowledge about how our occupational therapy culture is expanding and is building. And as all of you are aware, knowledge construction is related with is so relevant. 3 aspects. And it's so interesting because complex. Life make us think about the day like everything will be forever. And the last aspect that is characteristic of our global world is the vulnerability. All of us, we are vulnerable, not only the people that we serve, all of us, we are. And this is something that is also related to culture, because culture is not only the difference, it's also the shared values. And this aspect is also related with kind of values we are spending and focusing in our OT education. An intercultural perspective invites us not only to incorporate other knowledge, other occupational knowledge, but also other kind of narrative when we want to try to understand occupation, health, and well-being. And probably for that, as Professor Wendy said this morning, we need to ask people about what are the main narrative, what are the main experience for them. Of course, this could seem simple, but it's not so possible to do that if we are not able to reflect before in our main values. I mean, as human beings, we can offer others the thing that we don't have for ourselves. I mean that probably in our OT education system, we need to start allowing a student or allowing us as OT practitioners to reflect about these kind of things for ourselves, because it's the only way that we can be prepared to allow this kind of reflection with others, with the respect that they deserve. Of course, this intercultural perspective invites us to this core reflection, also to recognize diversity in the OT therapy practices. Do you know that, for instance, in South America, colleagues are talking about occupational therapies, different occupational therapies? I mean, probably it's not time to think about only one occupational therapy, but the diversity in our profession. And also to consider that our profession is completely linked with aspects like economic, political, and social aspects that we can ignore, because ignoring that, we are promoting a double vulnerability. I mean, we are being not only ignoring the situation, but being not responsible with the approach that we are doing. According with Ibn al-Rumi, that is a great spiritual master and leader, no? When you began that long journey into yourself, I think it's time for us to reflect about our own reflection. Or it's only not for granted, like it's something that all of us we share. I learned so much from the Moroccan student last year because I have been invited to share some courses in the OT educational program here in Rabat. And thank you so much for the Moroccan OT student because I learned so much from them about how the daily style of life in Morocco is completely allow me to reflect another that probably we need to incorporate in our research and in our education other epistemologies. And according to the Brazilian Sousa Santos sociologists, probably we need to incorporate in the South epistemologies. The South, not like the South part of the world, but the minority part of the world. That is the majority part of the world. And to finish, I would like only to share with you these two questions. First of all, I would like to ask you, how is your occupational therapy heart beaten? Hopefully it's beaten well and with hope and meaningful direction. But please, we need to have always in our mind these two questions, or at least this main question. Are we promoting consciousness occupations? And are we promoting social transformations? Okay. Thank you so much, and shukran jazilan.
Thank you, Dr. Inda, for this amazing presentation. But just before I forgot, after two presentations, we will have coffee, and please, and Sheikh.
Thank you very much, Said, to invite me here. I'm sorry about my English. I will try to make my best, but I will do it. But I was thinking, the PowerPoint is in English, French, and Arabic. I don't know French and Arabic, but Google Translator works. I don't know if you're going to understand it. Well, about the time, and I know I was the last one, or there is another person after me. It's the 18th. I was thinking it was a long day learning, and now Said sent me this subject, analyzing occupationally in order not to change humans' behavior. And I said, okay, I have a lot of time. No, I have only 10 minutes. I know, I have 5 minutes to do it. So I thought about to make a performance. Yes, really. And I have told someone I'm going to make a short performance. Well, it's a very simple performance. It's a joke. I think after my performance, you think about what I have done here. But after the performance, if you think I'm a clown, you are true. I am. But I hope when you go back home by the plane, or you are by train or by boat, we're going to take it later, you think about what that Spanish people done in the conference. So, well, I'm going to try. Let me see. I'm a little bit nervous. What do you have to do? Going? Yeah. What I'm going to do is analyzing my day activity, like dress up, in order to change my human behavior or my behavior. Okay? So I do it by washing me. I'm going to demonstrate that how I decided this morning to dress up for this speech will change, in French and in Arabic, will change my behavior, your behaviors, my results, and your expectation about what I'm going to talk about. And it will change my habits in giving a speech. For example, if I dress this way, that the dress I usually use for weddings, once every sometimes. What do you think about at this time today? Oh my God, another one talking about analyzing occupational behaviors. It's horrible. So I decided, no, that's not the option. But if I dress this way, wait a moment. Hello, I'm Dr. Paco Marquez. I'm teacher at Malaga University. I know I'm going to teach you about adaptation in occupational behavior with a long time, with a very specific word I don't know in English. So, what do you think about? Oh, no, my God, a terrible headache for this moment. Well, if I did this morning, I wake up and I decided, no, I'm going to be myself. I'm going to dress like I think I'm going to do. Give me a second. Wait a moment. Well, if I dress this particular way, hello, I love you. I love this conference. I love occupational therapies. Oh, I love everyone. What himself. You're thinking about that. Okay, so the last change. Now this one is so simple. Dress like a gag. This way is, hello, I'm Super Paco. I'm super OT, and I'm a super teacher, and really, OT is in the world, all OT in the world are super. So, I finished. How I dress up this morning, we decided your behavior, my behavior, your results, and we have not enough time. And after all, we are what we do to change who we are. Okay, this is the conclusion. You can read it later because we haven't got enough time. So thank you very much, and please contact me. Contact me because I would like to help occupational therapy in Morocco from Malaga University. So I give some cards, and you have my email. Thank you. Bye. Thank you.
I told you he's the version of me in Spain. All right. So our last presenter is Wafa Shuhani, and she is a medical student, and she has been also helping us for the last several years for her interpretation and her consultation with the students. So she will be sharing with you her experience.
Assalamu alaikum. Hi, everyone. Well, I'm not as captivating or funny as Dr. Francisco, so you'll have to bear with me for a second.
Stroke.
So I'm here to talk to you today about post-stroke depression and post-stroke anxiety. We all know that the prevalence of stroke is rising in the last years. On one hand, because of the increase of cardiovascular risk factors, and on the other hand, because of the improvement of treatment of stroke. The age-standardized incidence, the mortality, and the disability-adjusted life years declined over the period of 1990 to 2013. However, the absolute number of people affected by stroke increased across all countries, suggesting that the global burden continues to increase, with the majority of the burden being borne by low to middle income countries. What about Morocco? Unfortunately, we don't have a national stroke register in Morocco, so it is difficult to estimate the prevalence of stroke in the entire country. But according to a study that was led in Rabat and Casablanca, the crude prevalence of stroke has been estimated to be 284 over 100,000 for the population aged 15 years and older, which is relatively low compared to developed countries, but is still an important number if you take into consideration the aging of the population and the low income, the low socioeconomic status of our country. Patients who survive stroke, or persons with stroke, to put person first, as Dr. Susan said, suffer from physical disabilities, but also from neuropsychiatric complications. I'll just mention cognitive impairments, mania, delusional disorders, emotional ability, personality alteration, and PTSD. But most importantly and most frequently, they suffer from depression. After depression comes anxiety, which is the second most frequent, and that has been shown to be relatively correlated to depression. Apathy, on the other hand, is an interesting differential diagnosis that makes that could make difficult to differentiate between depression and apathy. So what is the global prevalence of post-stroke depression? It is estimated that 1 out of 3 patients who survive stroke suffer from this depression, which is a huge number. But the studies show a widely variable prevalence of post-stroke depression that ranges between 10% to 64%. Depending on the country, I'll give as an example studies from Germany that showed 31%, and studies in Jordan that shows up to 75% of post-stroke depression. So how does post-stroke depression develop? The pathogenesis of post-stroke depression is multifactorial and very complicated. Researchers have split in 2 camps. Those who support opposing views, some propose a primary biological mechanism according to which ischemic insult directly affect neural circuits involved in mood. Other researchers have been more prone to justify the post-stroke depression by psychological and social factors. What are the risk factors to developing post-stroke depression? Majorly, we have found genetic factors, such as some genes have been found to be incriminated, such as the serotonin receptor genes, or other epigenetic phenomena, such as hypermethylation. We have demographic factors, especially the female gender, but also low socioeconomic status. Medical and psychiatric history, especially history of depression and anxiety prior to stroke. Stroke characteristics, such as the severity of the stroke, and the location, which has been found to be especially in the left frontal lobe and in the left basal ganglia. Functional and cognitive impairments are also important risk factors to take into consideration, and social support, so that patients who live by their own, who have fewer social ties, have been found to be more prone to developing post-stroke depression. The screening and diagnosis of post-stroke depression. For the screening, there are numerous scales. Not one of the scales have been found to be more efficacious than other, and we should take into consideration the patient's disabilities and every other factor to choose the scale, which is beyond the scope of this presentation in 10 minutes. But we will mention for anxiety, hospital anxiety depression scale, the Beck scale, and the Hamilton scale for anxiety. And for depression, we'll mention the PHQ-9, the PHQ-2, and also hospital anxiety and depression scale. As for the diagnosis, the positive diagnosis is made by a prolonged interview with the patient that should take into consideration the DSM-5 criteria that define post-stroke depression, in two categories: the major depressive-like episode and the mood disorder with depressive features. For the major depressive-like episode, depressed mood or anhedonia must be present with at least 4 other symptoms of depression. And for mood disorders with depressive features, depressed mood or anhedonia must be present with 2 other symptoms of depression, both for more than 2 weeks. The diagnosis of post-stroke anxiety is also done by the DSM-5 criteria, which I will not go all through because it doesn't differ much for patients after stroke and prior to stroke. But I will mention here that the difficulty of diagnosis of depression after stroke is about that the symptoms sometimes could be due to the organic lesion of the stroke and not to the depression itself, and the symptoms may have nothing to do with the patient's mood. So I will quote here real estate agents and say that it's all about the location. So to believe that the patient has depression where it's actually due to the stroke itself. It's diminished concentration and indecisiveness, that is typical symptoms of damage to the executive functions, or fatigue or loss of energy that can be caused by damage to reticular activating system. So what is the impact of post-stroke depression and post-stroke anxiety, which gives the matter all the importance? It has a great impact on the patient after surviving of the stroke. It increases risk of morbidity and mortality in some studies up to 10 times more. It increases the risk of recurrence that has been explained to be due to inflammation phenomena, an increase in cortisol levels and cytokines that create a microenvironment more prone to a recurrence of stroke. It aggravates the disability on stroke severity, which again increases the risk of mortality. It decreases the patient's compliance to treatment and rehabilitation. I will not go all through these guidelines of screening post-stroke depression in patients, but we should all be aware of the issue, and we should try to screen patients for post-stroke depression as often as we can, especially if the patient is of high risk. Which leads us to the treatment. The treatment of post-stroke depression is multidisciplinary. As physicians, we concentrate often on the medications, but we often forget the other aspects of treatment that are as much as important, and we hope that it would improve now that we have occupational therapy in Morocco, especially in activity and helping patients with their social activity and physical exercise. We shouldn't forget to be there for our patients as a society, because social support is important for patients after stroke. Physiotherapy with stress management, cognitive behavioral therapy and counseling have their place, and also medication with the lead first-line treatment being the SSRIs. Which leads us to our study. As mentioned earlier, our study has for a goal to estimate the prevalence of post-stroke depression and post-stroke anxiety in the teaching hospital of Fez, where I am a 6th-year medical student, working with the Department of Epidemiology and the Public Health. This estimation is important because, unfortunately, we have no data about the prevalence of post-stroke depression in Morocco, so defending it for a start would be to assess this prevalence. We also want to assess the quality of life of these patients and collect socio-demographic data of this population so that we can deduce the risk factors that are particular to our population. I will share with you some particularities of a Moroccan population that makes the study important and also hard. First, that we have no stroke register, so the patient selection will be only in hospital if we choose one hospital or in a region. There is a high level of illiteracy, so working with auto questionnaires is out of question. That makes the study even more time-consuming because we should do an interview-based questionnaires. It's a low-income country, which is, as mentioned earlier, a risk factor, and so the prevalence might be a bit bigger than in other studies. Materials and methods of our study, as I said, it's led by the Epidemiology Department and Public Health. It is an ongoing study. It's a study that I'm doing for my thesis. The criteria of inclusion, we included all patients who had stroke and who are hospitalized in the neurology departments of the teaching hospital of Fez, but also patients who come to outpatients visits in the same hospital. We excluded patients with aphasia and severe cognitive impairments and dementia because of the difficulty to do the questionnaires with them, but we are aware there is a selection bias because, as we said, dementia and cognitive impairment is a risk factor, and for patients who are illiterate, which is the case for a lot of our patients, having aphasia means that they lost all means of communication to others, so they're more prone to post-stroke depression. As I mentioned, with the scale we're using, our interview administered, I personally interviewed more than 60 patients, and it's an ongoing study, so we're not done yet. The scales we chose are the hospital anxiety and depression scale and the short form 12 for the assessment of the quality of life. So this is just for reference, the hospital anxiety and depression scale, the Arabic version, which contains 14 items, 7 to screen for anxiety and 7 to screen for depression. The cutoff choice is superior or equal to 8, but we should be aware of the difference of some items being more discriminatory than others in the screening of caselessness. So short form 12 are for the quality of life. And as I mentioned, it's an ongoing study, so unfortunately, I still don't have the result to show you. But from a first view, what I can tell you personally, because I've interviewed more than 60 patients, is that probably the results would be a little higher than those of literature. And one of the most important factors is the low socioeconomic status. This is a picture just to show that social support and activity and being there for patients after a stroke is an important factor to prevent post-stroke depression. And thank you for your attention.
You know, people like Wafa are done, and conference. So this is the musical show we'll be having here at 7 o'clock, and you are all welcome to join us. But also, we will love to have you here again. We have our 3rd annual conference scheduled to be here at this beautiful place again at the University of New England Tangier campus in January 2nd, Saturday, January 2nd, 2021. So hopefully we'll see you all again. All right. I would like to thank everybody who participated today, UNE, who always hosting us with gracious welcome, and also the generosity of them, generosity of Global Impacts, the generosity of Target Print, and Morad, my friend, digital printing as well, who helps us with a lot of printing things. And also, I would like to thank the OT Association of Morocco board directors who are here with us, Professor Hajiwi, Professor Fortasi, Mariam Shrifo, Osima, and Naima. So thank you all, and I hope to see you again.